Good evening, everybody. How's everybody doing? Good evening, everybody. You're not biased, right? Hello, everybody. How are you guys doing? All right. How you guys feel after yesterday? You guys think you know the stuff? Listen, if you know yesterday, the stuff today is bogus. Feel good? Well, I don't mean bogus, but if you know yesterday, this stuff here we're going to talk about, research studies, it's all interesting stuff. All right, so you guys feel you know it, right? All right, so listen, before we get into probability statistics and stuff like that, this is like simple stuff. They can't ask much there, and a lot of times they don't. But let me ask you a couple of questions. So I got a good feeling because the people that I got a good number of emails from you, and the questions were very legitimate, were high level questions. So I understand hopefully that everybody pretty much understands this, right? Everybody feels comfortable, right? We don't have to know everything in the stuff, but we have to know a little bit about how to use this information. All right, so look at here. Deborah, let me send it to you guys again. All right, so make sure you guys, all right, don't bombard me now. I get off class tonight and I find 27 emails like I did in one of the other classes. Okay, go slow. All right, give me a couple today, a couple tomorrow. Okay. 27 just from the class. I mean, I got off 10 o'clock and I opened the email, it's 27. Calvin, at 27 from a class that I just finished, right? Come on, that's a lot, right? Okay, so listen. So look at this case. All right, so you gotta help me walk through this case. Let's do a quick review on stuff we talked about yesterday. Okay, so if you guys understand this stuff, you will be able to get all these questions. So look, a 72-year-old woman comes to me with headaches. I am suspecting temporal arteritis. Okay, so follow this now. They tell you in the question that in studies, 99.9% of the patients with temporal arteritis have erythrocyte sedimentation rates above 60. Everybody get that? Elevated. Elevated erythrocyte sedimentation rates. Okay? All right, so watch this now. I check an erythrocyte sedimentation rate on my patient. Her erythrocyte sedimentation rate is 18. What is the next step in the valuation of this patient? See, so this is a step 1 question, but it's also step 2 question. Hold on. So the question they're asking you, be careful. Hold on. See, hold on. Research for what? Right. So that's the answer. That's the answer. Research for other diseases. This is not temporal arteritis. Change the diagnosis, said Kanika. That is correct. Forget about the biopsy. When you have to do a biopsy, you do it. But why did I do the erythrocyte sedimentation rate? Because I know it's almost 100% sensitive. I said 99.9% of patients with temporal arteritis have elevated erythrocyte sedimentation rates. In this patient, the erythrocyte sedimentation rate was normal. It was 18. Remember I said they have above 60? Right? So I ruled it out. Does everybody understand that? I ruled it out. So what's the mnemonic I use? SNOUT. A sensitive test, a highly sensitive test is negative. I ruled it out. Okay? Everybody clear on that? Everybody understand that concept? If I was going to do a biopsy on this patient with a negative erythrocyte sedimentation, I would never do the SED rate, right? I did it to rule it out. Okay? Now, what if the used rate is elevated? Let's say now it is 100. Okay? All right, Shadi says biopsy, right? Because now you're saying, okay, maybe I got used, but I got to prove it, right? Now I got to get another test to confirm the diagnosis because it's not specific enough. All right, you guys understand that? Okay? There you go. Low specificity. All right, Elder, you got it, right? All right, beautiful. All right, so look at this. What is the role of incidence in sensitivity and specificity? How does it affect sensitivity and specificity incidence? Nothing to do. What is incidence? What is incidence? New cases in, right? What does incident have an impact on? New events. No, hold on. I'm right, good. Prevalence, that's what I was looking for. And if it affects prevalence, they affect positive predictive value and negative predictive value. That's what I wanted to know. Right? Everybody understand that? All right, somebody told me about a case in the notes, and I got to take a look at it because I didn't have a chance. But look, if somebody has a disease before the time you're looking at, you take away those cases from the denominator. Remember that? What cases don't count for incidence? Remember we said two cases don't count. Dead and who? And people that have the disease. Right? They come out because you can't get the disease. All right? Dead and no cases. How about prevalence? Who don't we count in prevalence? Dead only. Okay? Be careful. Dead in prevalence in incidence, people that already have the disease and people that are dead. Right? Everybody okay with that? Okay. What is the effect of treatment on incidence? The effect of treatment on incidence. None. Stays the same. Everybody understand that? When does incidence get affected? What has a high effect on incidence? Prevention. All right, tell me some prevention methods. Vaccines, risk behavior, right? Lifestyle modifications, right? Sexually transmitted condom use, stuff like that. Okay, education, Gina, wonderful, right? Diet, Mariel says, right? So for hypertension, dyslipidemia, of course, right? Prevention. All right, watch this now. Watch a question for you guys. The effect of statins. So they tell you this blurb about statins, what they do, right? You guys know what statins do, right? From your pharmacology and stuff like that and pathin. What do? They lower cholesterol, right? Prevent CAD, Atsuko. Very good. So you lower lipids to prevent CAD, both primary and secondary prevention, right? Aisha now is getting me all into this pharmacology. Clinicians, all this stuff that you guys know more about than anybody. All right, so look at this. What is the impact of statins? So they tell you these studies, right? What is the impact on incidence and prevalence of coronary heart disease in the United States? All right, so Sugam says, reduce both. That's the right answer. Okay, everybody understand that? It reduces both. Why? Why does it reduce both? Doesn't. treat coronary heart disease, but what does it do? Well, if you affect incidence, right, that affects what? It's a part of prevalence. Remember, what's prevalence? It's only incidence, times duration. Okay? Everybody understand that? Okay? Okay, very good. All right, so listen to this. Listen to this. Now, what about, right? They tell you that when the new methods of treating acute MIs, okay, look at this now. The new treatments of acute MIs, when you have to take them to the cath lab within 90 minutes and open them up, have been shown to be very beneficial. Okay? So what has that done in terms of incidence of acute MIs? That alone. None. No change. Everybody understand that? What does that affect? Prevalence. I mean, it affects people with coronary heart disease, that die from coronary heart disease because it's a treatment, right? Everybody understand that? So if you're measuring death from MIs, right, that probably decreases it. Okay? Okay, very good. Everybody understand that? Okay. Receiver operator characteristics. What do you guys know about that? What is that? The area under the curve. So, okay. Accuracy. So what is an ROC? What is it? It measures how good the test is, how accurate the test is. It measures overall accuracy and power of the test, right? Everybody understand that? It's just a way to see which test is good and which is not. That's all. All right? So what's the ideal test? Right? A line that goes straight up. This is an ideal test. So let me... Where's Adam? Adam, I can't find my... For some reason, I can't find my tools. I wanted to draw something for the class. All right, where did Adam go? Guys, I can't see my tools for some reason here. Let me see, maybe they're... Adam is known to take pizza break, huh? Okay, good. Maybe he's taking more than that. Let me do this 1 second. Nope, I can't find. Oh, let me see here. Draw. Okay, let's see. There you go. All right, I got it. All right, guys. All right, I'm not an IT specialist. I'll tell you that much. Right? You guys probably have realized that. All right. So, Chad, you sure about that, huh? All right. Okay, look at here, right? So so we're looking at sensitivity right here, and 1 minus specificity here, right? So what do we want? We want something like this, right? Right? You guys see that? It goes up like almost like a 90-degree angle, like that, right? So your sensitivity goes up, right? At the same time, as it goes up, you're not losing specificity, right? So this This is good, right? This is a good test. All right, so good. Right, you gain more sensitivity without losing specificity, right? Because this is 1 minus specificity. So as you go down here, you're losing specificity, gets smaller, right? Everybody see that? All right, so how about this test now? What do you guys think about this? What do you guys think about that? Well, that's like kind of, right, bad, Mario said, right? No good, because sensitivity, right, as it goes up, as sensitivity gets better, what are you losing? You're losing a lot of specificity, right? Remember, these are the things that people use, I told you, like, for the bombers, for the airplanes and the submarines, okay? So you like the one that goes up, right? That's the best one. So another way to think about it, think of area under the curve, right? The curve that has the more area under the curve, that's the better test. That is more accurate. Okay? Everybody understand that? So if they give you two curves and they're close to each other, pick the one to the left. That's the one with the most area under the curve. All right? So this is a good question for you guys. Okay? Everybody okay with that? All right. Now, do you guys remember? Do you guys remember the snout? What's the snout business? All right. So if it's a very sensitive test, right? It's over 90% sensitive. If it's negative, you're usually able to rule out the disease. The closer it is to 100%, the better. Okay? And how about spin? Spin. A very specific test, when it's positive, you use the P, right? Again, positive, it rules in the disease. It diagnoses. This is just a crude way to look at these tests. Okay? So when you guys are on the wards and somebody says, well, this test has a 97% sensitivity, you tell them, okay, I could use it to rule it out. Right? Use this on the medical wards when you're looking at tests. It's very effective. All right? Remember sensitivity. What's the definition of sensitivity? True positives, but it has to do more with the negative predictive value than anything else. Right? Specificity has to do more with the true negatives, right? True negatives. We're worried about, we want to know the truth, right? But what is it mostly connected with? The positive predictive value. All right, so I told you, seasoned clinicians, and you ask them about that stuff, and they start like, thinking that you could rule in a test with a sensitivity. Okay, so you guys know that you're one step ahead of everybody. Okay, all right, you guys feel comfortable now? Right, Miguel, the denominator. Right, the denominator matters. There you go. Okay? All right, very good. All right, you guys are great. Okay, so let's talk a little bit about probability basics. Right? So this is not big deal. It's simple. Don't make a big deal out of it. They can't ask complicated problems from you guys. You know why? Because they know where we got numerophobia. You didn't go to medical school because you were a mathematical genius. And anything that takes more than 30 seconds, they're unwilling to have you deal with it. All right? So that's the deal. Okay, so look at here. Probability statistics. You need to know 3 components of this. When events are independent, Avin, I love that. You are so right. That's good news. Whatever happened in the past is independent of future events. Independent events. You combine the events by multiplication. Right? Everybody understands that? Somebody says, what are my chances of getting 2 heads in a row? Right? I flip a coin and I get, we're going to talk about study design. You're going to talk about study design, they're going to ask you. Okay? But this stuff here, but it's easy to know. Right? So what are my chance of two heads in a row? And you know, this probability, this logic stuff here, you know, people have lost fortunes. You know, do you ever hear about the guys that play poker and, you know, dice and all that stuff? He says, if I bet enough, at some point, you know, I'm going to get, you know, heads. You know, but every time you roll, you know, a coin, it's 50%, right? It's 50%. That's right. So the chance of two heads in a row, you just multiply that, right? If you knew the prevalence of coronary heart disease, right? If you said, what are my chances that two people, the next two people I pick out of the population will have coronary heart disease, or will have hypertension, or will have hepatitis C? They're independent events, right? They're not connected. If one patient has hepatitis C, you know, the other guy may or may not. They're not connected, right? If you pick them randomly out of the population. So if I knew the prevalence of these diseases, I would multiply, just like I did with the two heads in a row, right? Yeah, but Miguel, by the time they see 10 heads in a row, by the time they rolled 4 times, they've lost their fortune, right? Everybody understand that? So you multiply. It's easy, right? You multiply 2 heads in a row, right? The chances are 50%. Be careful about, you don't multiply, 50% times 50%, 50, you do it as a decimal. It works out better that way. Okay? Everybody understand that? All right, 3 heads in a row, right? It's 12.5%, and so forth. Okay? Everybody okay with that? That's simple, right? So look, this translates to population statistics. Everybody understand what I mean? If I know the prevalence of a disease, I could tell you what are the chances that I will pick somebody from the population and they will have this disease, right? So if I told you the prevalence of obesity in the American population, right, is 20%, all right? And I pick somebody randomly. I pick the next guy off the street or the next woman off the street. What are the chances that this person will have obesity? Now, one person. I'm up to one person, Mario. Right? One person is what? 20%, right? Now, if I said, what are my chances, right, of getting 2 people, right? The next 2 people that I pick to have obesity. So now it's 0.2 times 0.2, right? Everybody understand that? All right, very good. Wonderful. Okay. All right, so look at here now. Yeah, so, right, all right. So if you multiply, right, does everybody understand that? When you multiply decimals, right, it's not 40%, all right? Do the decimals. And then convert it to percent if they ask you. All right, Tatiana said 4%. That's correct. Everybody get that? Okay. So if they're independent events, right? Independent events. Guys, if you multiply 0.2 times 0.2, you don't get 0.4. You get 0.04. See, don't worry. I've been there. We're not mathematical geniuses. Okay? This is in your notes. Okay, but listen, the reason I'm saying this is because the last time 3, 4 people, not from this class, sent me an email that, zero point 0.2 times zero point 0.2 equals 40%, right? Watch the decimals, okay? Watch the decimals. That's why I like doing it with the decimal and doing the multiplication, all right? Everybody understand that? 4%. All right. All right, everybody get it now, right? All right, use your iPhone to calculate it. All right, but everybody understands, don't use iPhone, I'm joking. Everybody understands what I'm talking about, independent events, right? Everybody understand that? Because you can't do it on the exam, Tatiana, that's why. I think, I don't know. But everybody understands what the meaning of an independent event where we multiply is. Everybody understands. Okay. All right. Very good. Okay. Wonderful. All right. I used to be really good when I lived in Europe most of my life, and I used to be good in math until I came here. All right. So look at here. So the second thing you guys need to know. Oh, we're gonna finish on time. Don't worry about it. So mutually exclusive. All right. So let's focus though. Remember, yours right. Okay. So mutually exclusive within a single event, right? If you get heads, you know you didn't get tails. So if I said, what are the chances that you're going to get heads or tails? Well, each one is 50%, right? And then you have 100% chance, right, to get head or tail, right? So if I say the next person that's going to walk down the street, is it going to, what are the chances it's going to be a man or a woman? Well, it's about 50% chance of each one, right? So it's 100% chance that the next person walking down the street is going to be a male or a female. Okay, everybody understand that? So mutually exclusive events, we combine by addition. All right? Simple stuff. All right, so what they may ask you, right? What they may ask you is non-mutually exclusive events. Okay, so watch this business here. Non-mutually exclusive events. Right? Mutually exclusive means that, okay, the chance of, somebody being, a man or a woman, kind of like, tall or short, right? But look, in medicine, a lot of events are non-mutually exclusive. They overlap. They overlap. Right? Everybody understand that? They overlap in what sense? That you have people that have diabetes and obesity and hypertension at the same time. So if somebody has, for example, diabetes, right, and hypertension, you add the events and subtract this part, this yellow part in the middle, which is the overlap part. Let me give you an example of that so you guys get it. So look at here. If the chance of having diabetes is 10%, what is the chance that 3 people selected at random from the population will have diabetes? You guys know this one, right? What are the chances? So this is what? 0.1, right? Times 0.1 times 0.1. Everybody okay with that? So the answer here would be 0.001, right? Everybody okay with that? All right, so everybody feels comfortable with that, right? So these are mutually exclusive events, right? Because they said in a row, right? If you selected three people randomly, right? They're asking you, look at here, 10% of the population has diabetes, right? If I chose one person randomly out of the population, my chance would be 10%. If I chose three consecutive people out of the population, what are the chances all three people, all of them, would have diabetes? These are mutually exclusive events, and you multiply, right? Everybody understand that? I'm sorry, they're independent. I'm sorry, I apologize. I'm sorry. Right, they're independent. Okay? I apologize. That's why I got you guys mixed up. Okay, right? Everybody okay with that? Okay? All right, so look at here now. Look at here though. So this is the example I just told you before, and if they do ask you this is the one that they likely will ask you. So look at here. All right, so we're talking about non-mutually exclusive events, right? This is the overlap business, right? So look at here. They're saying the chance of meeting someone who is obese and has diabetes, right? Or both, because there's overlap, right? Do you guys know about this? People that have diabetes, especially type 2, right? A lot of them have obesity, right? Now, do you guys remember the formula? What's the formula? We said A plus B minus the yellow. What's the yellow? Right. A times B. So that's it's just a formula to kind of be able to get our chances that these people will have one or the other or both. Right? So Kalpana says 37% B. Right? Everybody understand how some of you got that? Right? So, all right. So look at here. So in non-mutually exclusive events, right, there's a percent of patients that have both. That's what you're trying to figure out here. So it's not a man or a woman. It's obese or diabetes and people that have both. It's less because they have both. So a percent has both. What's that percent? 3%. How did I get 3%? Because the formula says A plus B minus A times B. What's A times B? The percent of patients in the population that have both. Everybody understand that? What's A times B? That's the 3% that have both. That's how you get both. Everybody understand that? Three percent is right here. This. Because that's the formula. That's what the formula says. The formula says that in non-mutually exclusive events, we subtract the sum, the product of A times B. That's right, 3% has both. Everybody understand that? when people overlap, right, they have this area in between. They got both diseases. All right. Well, what's A? 30%, right? What's B? 10%, right? Or 40, all right? So minus A times B, 3, right? Everybody okay with that? All right, Haley's Rocky. All right, very good. All right, so this one, we got to know. Okay, we got to know how to calculate this. We have to be able to say, when they give us non-mutually exclusive events, we have to be able to calculate this. Okay? Everybody okay with that? Okay. Okay, very good. So 37% is the answer here. Okay, so a little bit, I want to finish this hour talking about descriptive statistics. So it describes what you have. It focuses on the distribution. It's like a container of things. So I don't know specifically everybody in that whole container. I don't need to know. But I got a summary. Oh, guys, hold on. I mean, how did you guys get 300? It's 0.3 times 0.1. That's 3%. It's, guys, does everybody get this? Okay, the people that don't get it, send me an email. Okay, this is simple, not that difficult. Okay? You do the decimals, it's easier. Okay? You got to subtract from 40%, 3%. Minko, you could explain it in Bulgarian. It's good enough. All right? So 37% is somebody that has obesity or diabetes or both. You understand that? Because if they have both, you take out of the 10 and the 30%. That's why it's less. That's the 3% that overlap. Everybody understand that? See, if people have both hypertension, I'm sorry, obesity and diabetes, you take them out of the 10%. Okay? They are different between diseases, right? But you're saying, what are my chances of somebody being obese, diabetes, and having both? Yeah. If they got both, right, you're taking it out of that 3%. Okay? Just trust me. Okay? Everybody understand? It's not more, it's less. All right? All right. A or B, both. All right. Everybody okay with that? All right. You guys are going to do it tonight, and then if you got problems, you're going to come to me. Okay? All right. Well, you shouldn't ignore them totally, but listen, it's nice to do decimals. Okay? It's nice to do decimals because you're always right. Okay? Everybody okay with that? All right. So let focus a little bit on descriptive. I thought it was going to be with you guys did so well yesterday that I thought it was this going to be we're going to fly through this. All right. So look at here. Descriptive statistics, right? It describes overall the population, right? So we focus on the distribution, we summarize data. We summarize data. We don't focus on, all right, 2, 3 people in the population. We get a description of the whole population. So I may not know if I got a description of a whole high school class, I may not know that somebody's a genius in there, but I got a description of the 50 or 60 kids in that class or whatever, in that high school. Everybody understand that? So you lose the details, right? And you hold the essentials. That's what these descriptive statistics mean, because remember, epidemiology, what's epidemiology about? Is it about one person, 2 people, 1 family? No. What are we talking about? It's usually about what? The group. We're talking about big groups. Okay? The way we describe them, we describe groups, right, is through 2 ways. Central tendency. You guys know what that means? Central tendency. What's that? Central tendency. They tend to be central. What does that mean? Huge populations, right? Like a bell curve goes in the middle, right? Most points go towards the middle, the mean, right? Everybody okay with that? And then we got this other thing where we can describe a population where it's called like the average. That's right. That's what this is. And it's an average. Everybody goes towards the average. So this is important, because if people deviate from this, right? They've asked questions on the USMLE. The next time you measure this, what are you likely to do? Well, the next time you get some kind of point, right, in the population, you're more likely to go towards the average, right, the mean. Okay? So the 2 ways we do that is through central tendency and then standard deviations. This is the measure of variation. So we're going to talk about these 2 over the next 20 minutes. So this stuff, right, it's an abstract of the data, right? I don't have the whole details here, but I got a good idea what the whole population is about. Okay? All right, so look at here. This is central tendency. What do you guys notice right away? Central tendency. What do you notice right away? Most patients, so it's not only a curve, okay, says it's a bell curve. It's a well-balanced bell curve, right? It's a bell-shaped curve. So most population, unless there's something weird, unless there's something skewed, right, they follow this central tendency. They're symmetric. All right, so what do you notice? Most people fall in the middle, towards the mean, towards the average. And what do you notice here? A small percent, right, falls on each end, right? So these are small percentages, right? So look at here. If they ask you, if you find somebody and, he's very short, right, or very tall, let's say we're looking at height, right, and then the next thing you measure, right, the next person, what is it likely going to be, right? The next person is most likely going to be closer to the average, the mean, right? Because most people fall towards the center. Okay? Now this is important for screening tests, right? When we develop screening tests, right? We follow this central tendency business, right? Why do we follow it? Because it helps us do what? Set the age of screening, right? So I don't care in colon cancer if I'm going to miss 2.5% on here and another 2.5% here. I mean, I care about it, but I can't screen hundreds of millions of people in the world thinking about these two extremes here. I want to score close right to X right here in the middle, right? Everybody understand that? So I want, if that middle here is 60 years of age, I want to go 10 years before, 10 years later. That's why people get screened, right, at what? 50 years of age. And they go up to 70, and we usually don't recommend screening after that. Okay? Everybody understand that? All right, so very good. All right, so they may ask you, though, right, a little bit about the central tendency business, about what does it mean, right? And what does it mean about central tendency? What are the parameters that we use, right? We use the mean, right? You guys said it, which is the average. We also use the median, right, which is the midpoint, the 50th percentile. And then the mode. What's the mode? The mode is the most frequent value, right? All right, so listen, you guys got to know this. All right, look at here. This is questionable. I don't mean questionable that you should question it, but it could be a question on the boards. In a normal distribution, you got to believe me on this one, okay? In a normal distribution, these are the same value. If they give you the mean is 20, right? And they ask you, this is a normal distribution. What's the median? 20. What's the mode? 20. Everybody understand that? Yeah, it kills logic, but this is logic. Okay? They're all the same. Everybody clear on that, right? So look at here. If they don't tell you that this is a normal distribution, what are you doing? That this is a normal distribution. If this is a skewed distribution, they have to tell you that. Everybody understand that? So if they told me my mean is 20, let's say, I don't know, I'm measuring something, who knows, I don't know, some kind of lab test, then my median is 20 and so is my mode. They have to tell you that this is a skewed distribution in order for you to be able to figure the others out. If they don't tell you it's skewed, then you assume it's a normal distribution, and these are all in the same value. Everybody clear on that? Okay? Everybody okay with that? That's just the way it is. Okay? Now look at here. Rarely, all right, rarely they could ask you about skewed distributions, but it's easy to remember. Easy to remember, right? A positively skewed distribution, the tail, see where it's skewed, you see the tails, right? The larger tail is where it's skewed. So in a positively skewed distribution, the tail is to the right. In a negatively skewed distribution, the tail goes off to the left. Everybody see that? All right, so they may ask you about the mean and the median and the mode. And when it's a skewed distribution, right, from the tail, alphabetically, it follows that one is more than the other, right? So alphabetically, right? From a positively skewed curve, the mean, right, is more than the median, is more than the mode. How do you remember it? Because it follows alphabetically. from a negatively skewed curve. The mean is less than the median and the mode. Again, it follows an alphabetic order. So they may ask you, rarely, they mostly ask about normal skewed curves because 90% of curves are normal. That's just the way life goes. Okay? But they may ask you sometimes about a skewed curve, and they may ask you, what's number 1 here? What's point number 1? What's point number 2? What's point number 3? Right? You're supposed to say, alphabetically, number 1 is the mean, number 2 is the median, right? And number 3 is the mode. Okay? Everybody okay with that? All right. In a positively skewed curve, right, what comes first? What is more? What is higher? All right? What is higher? I mean, closer to positive, right? This is, remember, let's say, well, hopefully, the numbers get higher here as you go in here. So what has a higher number, right? What has a higher number in a positively skewed curve? It's point C, which is what? All right, so if I said this curve is skewed positively, right? And I gave you some numbers, you would know that the biggest number belongs to the mean. Okay? Everybody understand that? Closer to the tail, right? In the positively skewed curve. In the negatively skewed curve, again, it's closer to the curve, it's closer to the tail, but now because it's negative, it's smaller. Again, in a negatively skewed curve, right, the mean now is the smallest number, median, and mode. Okay? Everybody understand that? Follow the alphabet. Okay, very good. That's all they could ask you guys here. Nothing. Nothing else. Okay. All right. So look at here. So a couple of other things with measures of variation. Are you guys tired? Do I have 5 more minutes? Got 5 more minutes, right? Okay, 5 more minutes and then we'll get a break, all right? All right, I know I give you a lot of information. A couple of the other things that you may hear about, rarely, is in terms of measures of variation. So outliers are usually here, right? Outliers are here, right? In the normal curves, they're far to the left and far to the right, right? They're like the 1% here and the 1%. Those are outliers, right? All right. So when it comes to the range, they may ask you what the range is and how good is it in terms of measures of variation. Right? We said the mean, the median, and stuff like that is nice. It gives us an idea of the population. Right? The range is highest to lowest. So look at this. I'm measuring the height of students in a high school class. Okay? And it ranges from 6'7" to 3.5 feet. All right? What does that tell you? Well, it tells you the two extremes, right? Those are the outliers, right? And that's what you were talking about. That's the range. See, the range gives you the outliers. It gives you the two extreme points. Bigger and smaller, right? If you went back here, look at here, in a normal curve, what's the range? Here, right? And here. Everybody see that? So is that good? Well, sometimes it's good. I mean, you could tell, like, well, what's the range of SATs in a high school class? Okay, so you can see one guy totally, flopped, the other guy's a genius or something like that, studied his brains off. Right, these are extremes of variation. So look at here. The point I'm making for the USMLE is, why is range something you don't hear a lot about? Only in rare cases. And when you do, it's like kind of something like, in the Washington Post or the New York Times, they're basically trying to, cause a crisis, right? Because they're not reliable. Because you've got the highest and the lowest, which is the two extremes, right? The two data points. So it gives you an idea of what's going on. But the bottom line is that despite these two extreme scores, most people do what? They go to where? The average, right? If you said, well, what are my chances that the next person would be 6'7"? No, the next person is not going to be 6'7". They're likely going to be, I don't know, 5'8" or 5'11" or whatever, right? Everybody understand that? So the range, even though it gives you an idea of, what to expect, you don't really get your hands around this population. Right, it does. So, Melanie, in some cases, it's important. I'm not saying it's totally off, but in terms of scientific stuff, you see, you never hear a lot about the range. When you read manuscripts, they want to know the mean, they want to know the median, right? Right, exactly. So it's like no, it's not even 130/90. It's 200 over 110 versus 100 over 60, right? That would be the variability in blood pressure, right? Everybody understand that? You two extremes, two ends of the spectrum, all right? So you don't know what's going on in the middle. Why is the middle important? Because that's where most people fall. They don't fall in the extremes. So you say, "Oh my God, they got a student that's 6'7". Well, the rest of the population is probably not that way. They're probably much, less tall. Okay, everybody okay with that? So this range business is not a stable indicator. Okay, everybody okay with that? Right. So most blood pressures are around 120, 130. They're not 200, and they're not, 70 systolic. Okay, those are the extremes. Everybody okay with that? All right. You guys want to take a break? Let's take a 10-minute break. So we'll come back at 7:08. Okay? That's right. So that's why, see, that's what I'm getting at. We're going to use the standard deviation. Right? So because the standard deviation and the mean and the mode are better. Okay? All right. So let's take a 10-minute break and come back and talk more about this. All right, before we go a little bit further down, let's answer these two questions, okay? In a positively skewed distribution, what has the highest value? Is it the mean, the mode, the median? What is it? What's the answer to that? Alphabetically, what comes first? Remember, it goes to the curve. What has the highest value? I said, in a positively skewed curve. What's C? Which has the highest value? The mean, right? Provided this is a graph with going from low to high values of something, I didn't, guys, hold on. I said, which has the highest value, right? Everybody understand that? The highest absolute value. Everybody understand that? Absolute value. The answer is the mean. Okay? It's the biggest positive number. If you said, what is the highest in frequency, right? Which one has the highest in terms of frequency, right? In terms of where the population is. The answer now is the mode. You guys got it. All right? It's always the mode. So watch that. Okay, look at this now. All right, one more. We'll go back to that. All right, so look at this. You're in some kind of town in in uh, in California, in the mountains, right? And 30% of the population of that town of 12,000 has a Motorhead tattoo, right? Another 20% has a rose tattoo, right? That's a good that's the town where they're growing marijuana, right? And of course, there's some of them that have both. Okay? All right? So what are your chances that when you walk into town, you pick somebody off the street, they have one or the other or both? All right. Let's see what you guys think. Man, you guys are all over this. All right. So the answer is 44%. All right. You guys are great. Okay? 44%. All right. Everybody okay with that? So what is this formula about? Non-mutually exclusive events. They have to tell you they're not mutually exclusive because for all you know, they got one tattoo or the other and nobody's got both. They have to tell you that. Right? Everybody okay with that? Oh, good. So Miguel says, what are the chances that you're going to find somebody with both? Right? I don't care about one or the other. I want somebody with both. Good. Remember? So now it's multiplication, right? It's independent. So what is it? 6%. All right. You guys are all over this. All right? All right. See? Mariel says, piece of cake. All right, you guys got it. All right? All right, we'll go back to that. All right, so look at here. All right, you guys, you see this formula? You guys see this formula on standard deviations? Miguel says, even my cat got it. Right. So you guys got to know it by heart. All right? I'm joking. Do I look like a guy that can remember this? I just put it in your notes to know, to make you understand that, look, I just don't pull a standard deviation formula out of the ceiling. So you think that they would put something like this? You guys need about 10 minutes, even if you had a computer, right, to memorize this stuff. But listen, it's important for us to know that in standard deviations, when we write manuscripts and we talk about studies, right, we use these standard deviations and they come out of a formula where they use variance and all that stuff. What a standard deviation does is it measures dispersion. right? What does that mean? Try to tell me some in another way. What's a standard deviation? What does it do? Measures variability, right? From where? Well, Charles just said it. From where? From the x, right? What's the x? The median. So it measures variability from the mean. It measures dispersion from the mean, right? All right, if in a normal curve, look, Tatiana said the median. So in a normal curve, the mean and the median and all that is the same. Beautiful. So in a normal curve, it measures variability from what? From the mode, the mean, and the median, right? Everybody understand that? Normal distribution, the three m's equal each other, right? The three m's equal each other. All right, so the standard deviation, right, measures dispersion from the mean and the mode and the median in a normal curve. The more dispersion, the less precise, right? The less dispersion, right, the shorter the standard deviation, right, the more. No, actually, most physiologic events, Melanie, are not skewed. No, this has actually been studied. Most physiologic events follow a normal distribution. It's how we get those events and how we measure them that's skewed. Right? So look at this. I just did a study in veterans because that's how I could look at the database. All right? And that the bell curve is skewed. All right? So what is it? Is it because hypertension and exercise is skewed and obesity? No, it's because I'm looking at the population, right? Of they're only men, right? They're veterans, so that's a specific population. That's what is skewed. Okay, everybody, okay? Well, you're right. So listen, the standard deviation is very important, but look, you can't. Somebody said something brilliant there about the standard deviation and the p-value, right? So was it Carolina? Right. So the problem is, Carolina, though, if you don't have a good p-value, right, you can't publish a study, right? It's the p-value. If you don't reject the null hypothesis, you can't say, look, this study is important. So I agree with you, the standard deviations, right? And a lot of other stuff is very important, but in terms of science, right, publishing science and telling people, look, this is the truth, right, it's got to be less than, right, the p-value has to be, what's the magic number? We're going to do it. We're going to talk about it in a little bit. What's the magic number? Anybody know for p-value? Where you could reject the null hypothesis, 0.05, right? So that's the only way you could reject the null hypothesis and say, look, this is true. Okay? Everybody okay with that? Okay, very good. That's right, it's got to be less than that. All right? We'll talk about that. That tells us that what we think is reality. That's what, when you reject the null hypothesis. Right? Okay, so but you guys understand the standard deviation. That's right. You are definitely correct that when you see a standard deviation, you could see the study was modified, right, to get a better p-value. That's exactly right. A lot of people do that. All right, so you guys see this right here? We have to remember this. So if I could please ask you to this, I'm not joking now. We have to remember this. We don't have to remember the sums of the different ones, but we have to remember, right, three values, right? We have to remember one standard deviation on each side from each side, right, is 68%, right? 2 standard deviations from each side, from the x. What's the x? The mean, right, is 95.5%, right? Be careful. Not 95%, 95.5%. If you go 3 standard deviations from what? From each side, negative and positive from the mean. Everybody understand that? You go to 99.7%. Okay? Everybody understand? Theoretically, you never get to 100%, supposedly. All right? So, right, you guys got to be at 3 standard deviations on the right. Right? You got to be at 99.7% to the right. Okay? That's where you guys got to score, and you will. You will. So listen, what's the numbers again? Make sure it's to the right. All right? So 68, 95.5. Okay, watch that 0.5 because people got it wrong last time. 95.5 and then 99. If you remember 99%, you're okay. Okay? We use 2 standard deviations. So people say if you're 95%, 95.5% for the manuscript, Atsuko, they say, okay, you're good. All right, so what are your chances of missing it? 5%, 4.5%. Okay, you're fine. Okay? That's how people think in science. But what's your point? Your point is that you can make a mistake, right? You could think you got something in the study, right? Right, and it was a transcript. But you could miss things, right? Despite having 2 standard deviations, right? Your 2 standard deviations gives you 95% confidence interval, basically. That's what it gives you. But you still don't have 100%. But that's probably as good as it gets, right? Okay? Everybody understand that? So what are my numbers again? 68. Now, they usually give it to you, right? But I want you to remember these. 68, 95.5, and 99. They're not going to ask you 99.7, so it's 99.7%. But if you remember 99, you're okay. Okay? All right. So let's do a couple problems here so you guys understand what we're talking about. Now, listen, I want to before we do a couple of problems, look, I want you to remember that, look, it's not 68% 1 standard deviation on one side. It's 34 this way, right? And another 34 going that way. That equals 68% of the population, right? When it comes to 2 standard deviations, right? Now you add another 13.5% on each side, right? Everybody okay with that? Everybody understand that, right? If you remember 68 and 34.5 on each side, you got it, okay? Everybody okay with that? That's right. So if you said what is 2 standard deviations above the mean, right? It's 34 plus 13.5, right? 47.9 or something like that, right? 47.5, I'm sorry. Okay? Everybody okay with that? All right, Tatiana got me. 37.5, okay? If you said 2 standard deviations on each side, it's 37.5 on one side and 37.5 on the other side. Okay, so think about that. If you remember these numbers, you'll get them right. Okay, look at this now. In a normal curve, what percent of cases are below 2 standard deviations below the mean? Okay? Watch what they're saying. What percent of cases are 2 standard deviations below the mean? All right, so let's figure this out. So look at here. They're asking you right here at 2 standard deviations, what is below that, right? And you guys said about 2.5 here right? It's below, so they're asking you what's below the 2 standard deviations, right? So watch the language here. They didn't ask you, they wanted to know what's below the 2 standard deviations, right? They're talking about this right here. So what is that? That's about 2.5%, which most of you guys got correct, right? 2.5%. Okay, they didn't ask you what's 2.5 standard deviations below the mean. They asked you what is below the 2.5 standard deviations. What percent? Okay, Tandra, so what's the language here? What are they asking? Below or above or from the mean? Everybody understand that? All right, let's do a couple more and make sure you guys understand this. All right, so the IQ, all right, the IQ, they tell you the mean is 100. Each standard deviation is 15. Okay? What percent of the population has an IQ below 70? So that's what they use for disabled people, right? That's how they get who's disabled. And so you probably figure it out based on what I told you already. Right. So Maya says 2 standard deviations probably, right? Because that takes care of like 95.5% of the population. See? They don't so Miguel, I said to somebody, mental retardation, and they said, be careful because they're called mentally challenged, right? They went off on me, and despite I have people in my family that are mentally challenged, right? So that's what they call it. All right. So look at here. What they're asking you is, remember, the mean is 100, standard deviation is 15. All right. So the standard deviation, they're telling you right here, right? 2 standard deviations below the mean, right? You have to be right. You have to be politically correct, right? So the people that said 2.5%, right, were correct because it's 2 standard deviations below, right? Because they told us that the mean is 100 and the standard deviation is 15, right? So 70, you are 2 standard deviations, right? You go from 100, right, to 85, right, to 70, right? Everybody understand that? Right? So they're telling you at 2 standard deviations right here. And they're telling you what percent of the population is below that, right? So the same answer as before, 2.5%, about 2.5%, okay? And this is why I said they use this, the 70, the IQ of 70, for, considering people mentally challenged, right? Mentally challenged, because it's 2 standard deviations below the mean. Right? Everybody understand that? So remember, you're on the left of 95.5% of people, right? That's why they dub them as mentally challenged. Okay, now if that's right or wrong, that's another thing, but that's how they do it. Okay, everybody okay with that? You guys feel comfortable with this kind of questioning? All right, Miguel is all over this, right? So it's 2.5%. All right, let's do a couple more. In a normal curve, right? So they're telling us it's a normal curve, right? And if they don't tell us it's a normal curve, what percent of the cases are 1 standard deviation below the mean? What percent of the cases are 1 standard deviation below the mean? All right, I see. Well, it can't be probably 84, right? So let's look at it, right? They're saying 1 standard deviation and what is below, right? So hold on. I'm sorry. They're saying what percent of cases, so you may be right, so is above one standard deviation. I'm sorry, I missed that. Above one standard deviation below the mean. What percent of cases are above one standard? So see, I was saying, like, because I didn't read the above, you guys are probably right with 84%, but let's do it. So above one standard deviation below the mean. I think you guys are right now, right? So they're saying here's one standard deviation. What percent is above, right? It's 84%, right? Because you add, right, all this. This is about 68, right? And this is another 13 and a half, another 2.5, so it's about 84%. Okay? Everybody okay with that? And that would be B. Okay? Everybody okay with that? So watch the, beyond, below, and no, it said, Minko, it said, look, it said what percent of cases are above one standard deviation below the mean. So you're one standard deviation below the mean, and how many cases, what percent is above that? Right, so you have to know these values. They usually give them to you, right? Right, so they're asking you all this stuff right here, right, all the way up here, okay? No, they said what percent of the population is above one standard deviation below the mean. So you're at negative one standard deviation, right? And they say all of these numbers. Listen, they usually give you the numbers, but hold on. I told you to remember three things, right? I told you if you remember 68, 95.5, and 99, you guys will get these questions. Every single one correct. Every single one. Right? So even if they didn't give you the number, you know that one standard deviation on each side is 68%. Right? Right away. And then another 13.5 on the positive side. Everybody understand that? Well, no, I'm not saying so. I mean, listen, are you okay with this? I'm not saying so. Hold on. What are you saying? What do you mean it's not mathematically correct? I just want to make sure there's nothing that I've missed here. Guys, they're asking you right here, this population right here, right here. They're asking you right here. Okay? Everybody okay with that? All right. All right. Everybody okay with that? Okay, very good. 84%. All right. So here's you guys. A student scores the 97.5 percentile, right? Where does this fall on the curve? Right? Because you're 97.5 percentile of your whole class. Okay. So right here, two standard deviations, right? This is about 97% right here. When they, hold on, the reason why you guys, the people that got this wrong, right? Why not 3? Because at 3 standard deviations, what percentile would you be? 99.7% or something like that. I don't know, 98.3 or something like that. Okay? They're asking you, out of all the people that scored, you're at the 97.5 percentile. Where's the 97 percentile if you take this right here? You got 2.5% left, right? All right, Carolina disagrees. Well, tell me about it. Well, 2.5 standard deviations, right, would be somewhere here, right, between 3 and 2, right? There isn't a 2.5, but let's say this was true. But at 2 standard deviations, right, at 2 standard deviations, right, this is about 97 something percent. That's right. Everybody get that? I know it sounds crazy. You know, like you're saying, like, wait a second. You know, why is this not, 3 standard deviations? But that's what it works out to be. Okay? Everybody okay with that? So watch the wording here. Well, you're going to do them tonight, and you make sure you get them. They said, where does the 97.5 percentile? It's right at 2 standard deviations, right? Guys, 2.5 standard deviations is more than that. Does everybody understand that? 95.5% is standard deviations from the mean. You understand that? 97.5% means along here. You understand that? That's the difference. You add 2.5, that's right. You guys feel comfortable about that? Watch, they didn't ask what percent of the population do you encompass in 2 standard deviations from right and left. I did tell them they have to add. If you add all this, you get 97.5%. You don't get more. But you guys could do something easier. You could subtract this right here. You could subtract that, and you get 97.5. Okay? Everybody okay with that? So watch what they're asking you. Are they asking you 97% on each side? That would be half standard deviations. Right? If I asked what percent of the population is 97.5% from the mean, that's a different question. Then it's 2.5 standard deviations. It would be somewhere here, right here. You understand that? Between 2 and 3. I didn't ask that. I said this guy scored 97.5 percentile out of 100, where does he or she fall? That's a different question. Are you guys okay with that? I want to make sure. See the difference? The right answer here is 2 standard deviations. C is correct. Okay? All right? Watch it. What if I said, okay, watch this. What if I said, what I want to have, I want to include 97.5% of the scores. Okay? What standard deviation is that from the mean? See how different that question is now? What's the answer to that? 2.5 standard deviations. It's between 95.5 and 99.7. Okay? I didn't ask that. I said somebody scored 97.5 on the exam. Where is he or she here? Okay? 2 standard deviations. Right? This answer here is C. Everybody get that? All right. You guys got it, right? Well, if you don't get it, you're going to shoot me an email. All right? So I could explain. You're going to go over this stuff. It's going to take 10 minutes tonight, maybe tomorrow. Okay? Guys, look at here. When somebody scores a certain or has an IQ of a certain, right? Be careful. That's not the same as standard deviations from the mean. What do I put this question in here so you guys understand the difference between a score and a standard deviation. What does a standard deviation tell you? How much are people from the mean? So if I said I want to include 97.5% of the population, what would you guys tell me? We would go 2.5 standard deviations, right? From each side. What if I said that I wanted to include 99% of the population? How many standard deviations would you go from each side? 3. What if I said 95% of the population? Then you would say 2. But I didn't say that. I said this guy scored 97.5 percentile and it's right here. Right? Everybody understand that? Okay, very good. Okay, wonderful. All right, so let's finish this up and take a break and talk a little bit about inferential statistics. Right? So inferential statistics, what does that mean? I make references beyond the data. Right? So where do I make references? What do I tell? This is I'm doing a study. Right? I'm doing a study. And I come up with certain data. What am I making an inference to reality, right? To the world. So look at this. I take 150 people. That's right. That's exactly what I do, Mario. I put the results of the study I try to apply it to the general population. And people reading my manuscript, they're telling me if it's good or bad. They're trying to see, is it really applicable to the general population? So this inference is to truth, reality. I'm going beyond the data, right? Is it significant? But what's significant or not? Significant or not means, right, is it applicable to reality? I take 150 people, I give them a blood pressure medication, right? I compare him to another 150, which I don't give him this blood pressure medication, and I see if this blood pressure medication reduces cardiovascular events. All right, so when I go out and I tell people, look, my study showed that this antihypertensive worked very well, and it lowered blood pressure, not only lowered blood pressure, which is a secondary outcome, right? A secondary outcome. I don't care about lowering blood pressure. What do I really care about? What's my primary outcome? So this is good stuff for USMLE. When I do a study, what's my primary outcome? What is the important thing that I want to see it does in people? I don't care about lowering blood pressure only. What do I care about? Lowering what? Cardiovascular events, right? Cardiovascular deaths. So when I tell people that this works, I'm really, you know, yeah, Shuzma, that's what most, researchers say. All they care about, they don't care about, decreasing death. They care about if it goes to the New England Journal of Medicine, right? But in reality, though, when we make such inferences, right, that we're really saying that that basically this is, real life, and I am, and if I put it out into the public, I'm able to prevent cardiovascular events in the population. Okay? We do this by confidence intervals, right? And p-values. All right? Remember you guys were talking about the null hypothesis before? All right? Carolina was talking about p-values. This is it. So this is the way we make inferential statistics inference to the truth, through confidence intervals and p-values. Okay? All right, so you guys know this stuff. So this is good stuff for USMLE. All right, so this logic stuff that we were going through first and everybody was getting bent out of shape, it probably is not, high risk stuff. But this stuff here, confidence intervals and p-values, it's definitely up your alley. Okay, so look at here. So I take data, right? This is reality, right? And through the confidence intervals and the p-values, right, I'm basically trying to make a reference to reality. So if I tell people, listen, you could use this blood pressure medication, this antihypertensive, right? I say, look, I tried it in 150 people, but, you take it out to the public, it's going to have the same effect, right? Everybody understands that? That's very important because one of the things they ask you guys, and we're going to be talking over the next couple of hours, you see that sometimes we skew the truth. We don't want to do it, but we take such a small sample of things, right, that we don't get to reality. So I tried this antihypertensive in 150 people, right, but these 150 people are not really representative of millions and millions of people. This is why, you see these manuscripts that look good, and then people come out and say, look, this is bogus. You tried them in, people that, were this or that, or didn't have comorbidities like the usual population does, right? So Melanie says, yeah, sample size matters. Absolutely. Sample size, that's why sample size is so important, right? Nobody could publish now, in a good journal without having, thousands of patients. Serious journals don't publish small numbers because it's non-representative of reality, right? It's biased. That's right. But we use these confidence intervals and the p-values, right, to make data, right, inference, right, to reality. Okay? All right, so here's your confidence interval. All right, so what do you guys think? You guys think you need to know this formula? So this is like the standard deviation, right? You guys know? No. All right, you don't need to know. But again, I put it in there just to show you that confidence intervals are calculated. And when you guys do studies, and then some of you have emailed me already that you guys have done research, significant research, right? These are calculated. You put them in a formula, and the computer calculates these confidence intervals. A confidence interval comes from the sample, right, that you're taking, and you're making inferences to the population. And what the confidence interval tells you is how far above and below a value is the possible truth, right? How far above and below. It really is about precision. It tells you about statistical precision. Okay, so let me give you an example of this, right? Not last year, the year before, right? I was in Chicago with the elections, the night of the elections, and I was uh, lecturing there in Chicago for step 2, and I was with a couple of guys, a couple of students, and we were watching the elections on TV, right? So look at this. And before anything came out, I think it was the day before the elections, right? So they had that Mr. Romney had 44%. Yeah, so this, if you guys understand this here, right? They put it at, at a little bit more clinical in step 2 and step 3. So this is all over step 2, all over step 3, all over the boards of medicine. So they had Mr. Romney at 44%, right? And Mr. Obama at 48%, right? They had a sample in the Midwest of 1,000 patients, right? They said, and I saw the blurb, and it said, Mr. Romney and Mr. Obama in this population, right, are almost equal, right? Are equal, right? And the student next to me, says, well, wait a second, what do you mean they're equal? One is at 48%, right? Right? And the other one is 44%, right? And then you look at something a little bit more, right? You look at the confidence interval. They said with a plus or minus 3%, right, confidence interval. So what does that mean? 3% on each side. So if you think about it, right, 3% on each side, that's Mr. Romney, and then Mr. Obama, right, would be anywhere from 51 to 45%. That's right. So, well, hold on. So once these intersect, you guys see that here? Once they overlap, what does that mean? You can't make any judgment, right? If they overlap, what does that mean? There is no difference. There can be no difference. Obviously, you know the results, right? But the bottom line is, if these confidence intervals overlap, you can't make a judgment call on this, right? Because it could be that Mr. Romney's at 47% and Mr. Obama was at 45%, for all we know. How did they get the 3%, Mariel says? How did they get the 3%? How did they get the 3%? How did they get the confidence interval 3%? There you go. Marco says, what I asked you not to remember, that's how they got the 3%. They plug in these, it's a model of statistical precision. So they measure variance, they measure numbers, right? So the higher the number, the more the confidence interval goes down. It's slender. Why? Because you got a bigger sample size. If you got only 1,000 people, that's a small sample size, right? So you can't, then you get big confidence intervals, like 3% on each study, on each side. See that here? 3% on each side. So what I said is, if these confidence intervals overlap, like the 47 and 45% here, you cannot make a call that there is a difference in these numbers, right? Yeah. So Walter says, is this 95% confidence interval? That's what this is. This is within 95% confidence interval. It's never 100%, right? Everybody understand that? We always like 95%. All right. So Iram says, if the sample were bigger, what would happen to the confidence interval, right? Let's say these guys did 100,000 people, right, in Chicago. What would the confidence interval be? Now you would be more sure of the result, and the confidence interval, instead of being 3%, it would be 0.4% or 1%. Everybody understand that? So what makes your confidence interval go up? When you're more confident, what makes your confidence interval be more precise, smaller? When you're more confident, right? A larger sample size. Be careful. This confidence interval, when they give it to you, it's within a 95 percent confidence interval, meaning that 95% of the time this is right. But the confidence interval is a number. It's a raw number. It could have been 5%. If you only looked at 10 people, right, on the corner of Michigan Avenue in Chicago, your confidence intervals would have been 10% on each side. The higher the number, the confidence interval is smaller, right? Because you're more sure, you're more confident of your results, and you don't need a large interval, right, to be sure. Okay? These confidence intervals tell you that your numbers are not precise, so you need a little wiggle room on each side to make sure you're in the clear. Everybody understand that? So Malaya said it right. 95 is being calculated for a sample size of 1,000, right? And you need 3% on each side, right? To figure this out. Okay? What it's saying is you need these confidence interval to your prediction to be closer to the truth. Right? That's right. Your 95% confidence interval here is plus or minus 3%. Okay? Everybody understand that? We're only as good as 95%. That's all we go. We could do more than that. We could go to 97%, but then your confidence intervals get bigger. So we say, okay, 95% is good enough for the truth. All right? Yeah, sure it is. But then your interval would be higher, and then, nobody would get a result. So I just told you where it comes from. I said, when we talk about confidence intervals, we talk about 95% confidence intervals. That's the standard. Everybody understand that? What does a 95% confidence interval mean? The number I get here is going to be 95% of the time right. Okay? 95% right. So for Mr. Obama, what was 95%? That he would have 48% plus or minus 3% on each side. Everybody understand that? For Mr. Romney, what would be my 95% confidence interval, which means what would I get 95% of the time? That I would have 44%, he would have 44% of the votes, plus or minus 3% on each side. So what does the confidence interval give you? wiggle room, right? All right, Kalpana says again, how did I get 3%? That's right, but that's the whole moral of this story, that in this population, it wasn't significant. It wasn't significant. It's given from the equation. I got it from the equation. There's an equation, there's a statistical equation. No, you don't need to know the equation. They got to give it to you. They have to give it to you. That's right. So Charles says 95% confidence interval is related usually to your p-value, and I'll talk about that in a little bit. They have to give you the value. They have to give you the confidence interval. They can't ask you to calculate. Tatiana said 97 is more precise. 100 is even more precise. But in order to get 97 and 100, you would have confidence interval. Nobody would ever be able to make any conclusions. Okay? Everybody understand that? Charles says 95% has been established as the standard. That's the right answer. The standard for what? We say, okay, in order to make inference to the truth, we need to be 95% right. Because if we try to be 100 or 97, we would never be able to publish a study. There wouldn't be a New England Journal of Medicine. And studies would cost hundreds of millions of dollars to be able to do that. Everybody understand that? All right, so tell me, last thing, what is a confidence interval? What does it give you? The error of measurement, right? 95% of the time. The wiggle room. That's right. Okay? All right, look at here now. Last thing, and you guys will take a break. If you remember what I said, can you guys see these confidence intervals here? So this is 3 drugs used for blood pressure. All right? This is what they got for 1. This is one they got for B, right? This is one they got for C. So just amuse me. That's what they got. Okay? Z-scores? Z-scores, are you talking about osteoporosis Z-scores? Or variance scores? You're talking about variance scores? You don't have to know them. Okay? The confidence intervals are absolute units. They are absolute units. Okay? All right. So you guys see these drugs? Okay? Because that's what the confidence interval was. 3%. That's what it was. That's what the formula says. It could have been 7%. It could have been 5. It could have been 0.4. Everybody understand that? It's an absolute number. All right, so look at these 3 drugs. All right, so these are the confidence intervals. You guys see that? All right, I'm drawing them so nobody says they can't see them. All right, so the dot in the middle is the result, and the confidence interval is, right, these 2 lines on the top and the bottom. Everybody see that? Okay. So drug C has a better confidence interval. All right. Now watch this though. If you compare these drugs, right? If you compare the efficacy of these drugs, right? In terms of blood pressure lowering capability, all right? I'm helping you out here. I'm drawing a line across here. All right? What is the only thing you can say about drug A? So drug A is a drug that you guys are trying to show that it makes a difference. So once it shows you make a difference, and you get this published and it gets FDA approved, you guys are going to be going around in a Lamborghini. But what is the only thing that you can say? All right, Marcos got it. There's a difference with C, but not with B. Okay? So look, the dot is blood pressuring lowering efficacy, right? So this is low, all right? This is high. You understand that? All right, so these guys came out. This is actually a true study. All right, these guys came out and they said, oh, our drug A is better than B and better than C, right? Because look, here's what I got here. Here's what I got here. All right, here's what I got for C. So A is better than B is better than C, right? Okay, I'm a millionaire. All right, but then you guys look at the confidence intervals. And what do you say? All right, Sushma says, but you can't compare with B. Why can't you compare it with B? Because they overlap. Once they overlap, the confidence intervals overlap, you can't make a statement that it's better. Okay? Everybody understand that? All right. Can you say anything about A versus C? A is better. All right. That's the only thing that you could say. A is better than C. A, we didn't show A is better than B. We don't know. Too much overlap. Okay? Everybody understand that? They may show you something like this. A is more efficacious than what? Than C. It's unclear if the efficacy is better than B. Why? Because I'm not confident enough. Because my confidence intervals overlap. And if they overlap, doesn't show that one drug is better than the other. If they overlap, you may not have an effect. See? They may be the same. Well, A is better than C because look, the confidence interval goes up to here. So that's the worst thing you could have, right? And that is still better than C. You understand that? Everybody okay with that? All right, Haley likes it. All right. Everybody, they may show you this. Well, overlap is a killer because if it overlaps, hold on. Don't, listen, I'm like Dr. Turco in this. Don't learn, overlap is bad. It's gotta make sense, right? Why is overlap bad? Because overlap means that there may not be an effect. Okay? If there's no overlap, then you're 95% right that there's a difference. See, back here, when we were looking at Mr. Obama and Mr. Romney, we said, based on the confidence interval, right, one could have had up to 47%, and the other one could have been down to 45%. So that overlap means, who knows? It may be totally different than 44 versus 48. There's a gray area. That's right. Everybody understand that? Okay, you guys feel comfortable? That's right. Okay. All right. You want me to stop there so we take a break? Let's stop there and take a break. Okay? I'll leave it here and then... All right, break. 10 minutes. All right. I'll see you back here in 10 minutes. All right. Okay, everybody. I got booted out and then came back in. Hold on, let me just fix my screen 1 second. There you go. All right, there we go. All right, so listen. Do you know why you guys feel bad? Because now you know some things. If you didn't know anything, you think you're doing great. When I first took this course, I came out, I didn't know what hit me. But if we know these basic things and we know how to apply them, yeah, well, I hate to say that. Yes, when you don't know, you're happy. All right? So please, you know more than you think you know. Just, focus on the stuff we talk about. All right? I'm going to talk a little bit more about inferential statistics. We're going to talk a little bit about the studies, and then I'm going to go back kind of like in the middle of the book. I want to finish off talking about biases, right? Because that's a hot topic lately. Okay? If I thought that you guys were doing bad, I would let you know. So I think you guys are fine. Just focus on the stuff that we talk about. Okay? Everybody okay with that? All right, Maria. All right. You're going to understand it. All right. So remember, we were talking about inferential statistics, and we said, what's the inference here is about going from data using confidence intervals. We already talked about confidence intervals, right, to reality. And now we want to talk about p-values. No, I'm not, listen, I'm telling you guys the truth. I'm being very honest with you because I have to be honest. When some people send me some crazy questions, I have to be honest with them. But I'm telling you, you guys know this stuff, and if it's good that you're asking questions. You're listen. You're not saying, look, okay, 1 and 1 equals 2 here. You're asking questions, okay? So, but I'm trying to make it. Yes, I'm trying to make it easy because I think you guys are getting it, and just stick to simple stuff that we talked about, okay? All right. So, what's the two ways we talk intervals, and we talked about confidence intervals, right? Oswald said his confidence is bruised, all right? That has a plus 5%, plus or minus, so you're okay, Oswald, all right? So that you got a little leeway there, all right? Okay, so if you remember, the Obama Romney example, I think you guys will get it, what a confidence interval is. Remember, if they overlap, there's no difference. You cannot speculate that there's a difference. Everybody okay with that? All right, so let's finish up talking about p-values. As some of you have mentioned, p-values are very, very important. That's another way to talk about science, talk about statistical stuff, right? So this is statistical inference. The p-value is statistical significance, right? Remember, you guys were talking about it before. You can't prove anything in the world. That's what logic says. You cannot prove that. This is, Aristotelian logic. And somebody asked, yeah, I am Greek. So they said you cannot prove anything. What is the only thing you could do? Is disprove something, right? If you fail to say, okay, it's probably true, right? Everybody understand that? That's the null hypothesis. So what's the null hypothesis? The opposite of what you want. Miguel, that is a 12-hour conversation with a lot of wine, right? Why is that? Trust me, you guys don't want to get into that now, right? Just trust me. So you got to I know you're, but I need to finish this stuff, right? So you guys need to know about this stuff for the test, all right? So you can't prove anything. That's the premise null hypothesis. I could only disprove something. If I fail to disprove it, then I'm essentially proving it. So I come up, when I do a study, with the null hypothesis. What's the null hypothesis? It's the opposite of what you want. All right, you remember the study we did before? I gave blood pressure medication to reduce blood pressure and reduce cardiovascular events. What's my null hypothesis? The medication does not work. There you go, Miguel. And if I can't disprove that, then I proved it. Okay? Mariel says that the medication doesn't lower blood pressure. That's right. And the medication doesn't reduce cardiovascular events. It's not going to work. And if I disprove that, if I can't disprove that, I'm sorry, if I can't disprove that, then I'm essentially proving it. Right? Everybody understand that? Okay, so there's two types of null hypothesis that you guys don't have to worry about. It's called a one-tailed or a two-tailed. It doesn't, you guys don't care. But you may see something like that and all you guys care about is the null hypothesis. Okay? If I want to show, no, this is not low yield. Oh, yeah, Miguel, the one-tailed, two-tailed, they're never going to ask you that. But the null hypothesis, they ask multiple times, right? The null hypothesis says, right, that this medication does not lower blood pressure, right? If you find a difference, it's just, random occurrence. Okay, Kanika? That's it. That's all. That's what it says. So what if I was giving a medication, a new drug? My friend called me up to look at this manuscript on a drug that's going to be used for CLL, chronic lymphocytic leukemia, right? So what was the null hypothesis these guys came up with? Hold on, forget about disproving it. What was the null hypothesis? The medication does not work on CLL, right? This is CLL, chronic lymphocytic leukemia, right? It doesn't cure CLL. It doesn't improve survival. Right? That's the null hypothesis. So if I don't prove the null hypothesis, I disprove the null hypothesis, I'm essentially proving that it works. Everybody understand that? That's the concept of a p-interval. All right? So look at here. I'm taking the data, right? I'm putting it in the computer, and I get all this stuff here that nobody cares about and no clinician could figure out. Right? We don't care. T, chi-squared, and all that stuff, variance, I don't care. I care about the p-value. If my p-value is less than 0.05, right, then I disprove the null hypothesis. Right? So let me show you. So here's the researchers, right? Here's the researchers. They take this line here, and they say, I'm not going to, that my null hypothesis is that I don't lower blood pressure. The p-value has to be less than 0.05. So let's take the one possible outcome. The p is 0.2, right? I just rejected the null hypothesis. Okay, so if I rejected the null hypothesis, what does that mean? What does possible outcome number one mean? The medication works, right? Works. Okay, you guys are doing great now because you guys are going to go out and buy a Bentley, right? Because your drug works, right? What if the p-value is above, okay, 0.05? So it was 0.13 in this case. I did not reject the null hypothesis, right? What does that mean? If I didn't reject the null hypothesis, it doesn't work, right? Questionable works. It doesn't work. I can't do it. Let me make it simpler. Does not work. Okay? Forget about the sample size right now. Okay? The sample size matters in the results. Now you're going for public transport, right? Public transportation, right? Everybody understand that? Well, if you take, do you guys know how much it takes to do randomized controlled trials on drugs? It takes about anywhere from $70 to $100 million. In most cases, that's right, Haley said about 13, that is the mean, anywhere from 10 to 13 years to prove it, right? And most drugs, as you guys mentioned, do not work. They can't, right? They do not reject the null hypothesis, right? Everybody understand that? If something works, then you got to show a p-value of less than 0.05. What does that mean? I rejected the null hypothesis. See, this was possible outcome number one. It was p02. That's just an example. Anything less than 0.05. Okay? Everybody understand that? Okay, so two things they ask here. So now they've gone one step ahead, and they ask in the USMLE one more issue. When you say a drug works, well, hold on. We said, Mariel says always less than 0.05 means that it worked. Yes, it means that it worked. Okay? It means that it worked, but hold on. There's still a risk that there's a mistake there, right? All right, Miguel says 95% of the time. You see that now? See, now you guys are thinking like statisticians. 95% of the time. Like the time that you're right about rejecting the null hypothesis. Everybody understand that? That's right. It means that you did the opposite of the hypothesis, which was the opposite of what you wanted to do. And 95% of the time, when you reject the null hypothesis, you're okay. 95% of the time. Okay? No, not choose my, not 5%. You cannot reject. What's 5%? What's 5% here? What's 5%? It's a random error that you showed that the drug worked, right? But in reality, it doesn't work. It's an error. It's just random. I don't know why it happened. I don't know. They fixed the study. Who knows? This is called a type 1 error. So what's a type 1 error? That you showed that the drug works, but it didn't work in reality. What is that called? An error, a type 1 error. Everybody understand that? So now I'm going to go around. Well, you don't care. You don't care that it's false because the studies showed that it worked. So for the time being, right, you guys are going to be going around in the Bentley. But what's the problem? You're going to be giving people blood pressure medication, and you're not really going to make a difference in their outcome, in their life, right? Oh, many times it has happened when people have given medications. Do you guys know this drug Zetia? Zetia, right? It's a lipid-lowering medication, right? And people found out later that even though it would, ezetimibe, right? That it didn't, lower cardiovascular events. Many times. Well, Vioxx was a different story. Vioxx did what it was supposed to do, right? Vioxx, though, you know where the problem with Vioxx is? It caused cardiovascular events as a side effect. And the company forgot to tell people. Forgot to tell people. Forgot, quote unquote. That's where they got in trouble and they had to pay a couple $1 billion. That's where people get into trouble, when they don't tell people what the side effects. Okay? That's the phase 4 trial, Melanie. That is exactly right. Okay? So you guys are okay with this stuff here? All right? You feel good. All right, so what's type 2 error? And you know what a type 2 error is? A type 2 error, you show that the drug didn't work, but it really worked. Right? That can happen too. That's a type 2 error. So in reality, you guys are going back to the drawing board trying to find another drug when this drug really worked. Right? That happens also. Okay? That's called a type 2 error. Anybody know what's worse? What's worse, a type 1 error or a type 2 error? Type 1, why? Why is type 1 error worse? It's an alpha. Okay, why is it worse? Why? All right, because it's worse to give patients a medication, right? The risk of harm, that's why. Right, rather than say, okay, they weren't getting anything, all right, they're not going to get this medication, but they weren't getting anything anyway. Okay, it's worse to give the drug that doesn't work because of the side effect and the harm it does to patients. Okay, so let's repeat this here, right? Yeah. So Miguel says, why don't I increase the power of the study? Some people do that. So if they don't show an outcome difference, they say, okay, let me continue the study. Let me put in another 1,000, 2,000 patients. Maybe I'm going to see a difference. Okay? They are bad, but listen, the first thing in medicine is do no harm. That's more important. A type 1 error is the most important error. Okay? Well, no, I mean, Claudia, most people make a type 1 error on purpose. Why would somebody make a type 2 error on purpose? I mean, they're spending $70 to $80 million. So it's not likely that they're going to make it on purpose. Type 1 error sometimes is on purpose. Okay? Everybody understand that? So what's a type 1 error? When I rejected the null hypothesis and I showed that the drug works, but it doesn't really work. Right? What's a type 2 error? When I did not reject the null hypothesis, so that means the drug doesn't work, but it really works. Okay? Everybody okay with that? All right. So a little bit more on this. So we talked about these two things. So remember this 95% confidence interval here, right? That's the p-value I was talking about before. Right? So you rejecting the null hypothesis, even if you do it, right, 5% of the time you may be wrong. Okay? That's all. So I want to say this one more time, right? The standard is to set your p-value at less than 0.05. That's what we do. We set it at less than 0.05. If we show a p-value less than 0.05, then we reject the null hypothesis. That's the way it is. It's at 95% confidence interval, right? That's the way statistics work. They never go 100%. We would never be able to prove anything. Once we reject the null hypothesis, right, then we say it works. So this guy here, it works, right? And now we go out and we give the medication to the public. All right? We still have a 5% risk of a type 1 error. What's a type 1 error? Type 1 error means that I showed that the drug works, but it doesn't really work. Okay? Everybody okay with that? If P is equal to or below, you're okay. All right? Everybody understand that? Less or equal to. Everybody okay with that? All right. If it's above 0.05, now you're zapped. You're zapped because what happens now? It doesn't work. All right? So now you do not reject the null hypothesis. All right? So the drug doesn't work. So you either go and you try it in a larger population. Sometimes that's difficult because some of these drugs have side effects. So it's kind of hard to go talk to people and tell them, look, I already did a study in 1,000 people and it didn't work, and I want to try it in more people because I want to be sure. Well, that doesn't fly sometimes. Okay? But the bottom line is you showed that it didn't work. A type 2 error means that you failed to reject the null hypothesis. You didn't show that this drug worked, but it really does work. Okay? So there was this drug for multiple sclerosis, long time ago, right? Not long time ago, about 15 years ago, it blocked potassium channels. So when they took it out in about a couple hundred people, it didn't improve outcomes in multiple sclerosis. Okay? So later, it's not in the market anymore. Okay? Later, some people were using it for other reasons, and it just happened that some patients had multiple sclerosis and they got better. So they retried it in a different population and they showed, right, that it really does work. It's just that they had such a small number when they first tried it out that, it just didn't show a big difference, right? Everybody understand that? Everybody okay with that? All right. So you guys got to know this. So this is material that is very testable. Okay? Right. So it depends on your size, it depends on the population, and stuff like that. Yeah, this is high yield. Right? The null hypothesis and the p-value is high yield. Okay. All right. So you see, now watch this. They asked this, recently, right? So they said, what do you need the p-value? That's how you make statistical decisions, right? So they tell you statistical significance, right? Statistical significance. That's all. It works, it doesn't work. Okay? Not clinical significance. Right? Watch this. All right? So be careful. You got to read in the lines there. When these guys show, the drug companies show a difference, you got to see if it really is important. Right? They showed in a recent study that this guy could walk, statistically significant, a COPD patient could walk, 20 extra yards, when they took this bronchodilator. Well, 20 extra yards for most people, who cares, right? Everybody understands? So be careful. Statistical significance, say p-value, says their difference. Clinical significance is what really matters here, right? So watch that. So it's not only statistical significance, you got to see clinical significance, right? So one person, so 200 people got the drug, 180 got relief, 20 didn't. Okay, this is statistically significant, right? Right. So those 20 yards may matter. I didn't say that, but there's some studies that it doesn't. So, like you see these pain study scales. All right, it went from 9 to 7, right? So this is statistically significant. But the patient, for the patient, it doesn't matter if it's 9 or 7. They want the pain to totally go away, right? So watch the clinical significance because that's what really matters. Okay? Okay. So the p-value doesn't tell us, the chance that an individual will get a benefit. It doesn't tell you the percent of patients who likely will benefit, exactly, and the degree of benefit. Be careful about the clinical significance here. This is right, the more important thing. Okay? Everybody okay with that? All right. So statistical power is the capacity to detect a difference when there is one, right? That's power. And it's inversely related to type 2 error. Now, you guys remember type 2 error? What's a type 2 error? Beta error, what is it? What does it mean, though? Right? That's when what? It didn't work, but it actually works. That's what I wanted you to know. Right? All right, so now you guys know the answer to this. How do we increase statistical power? You guys are all over this now. How do we increase statistical power? What's the answer to that? Sample size, more people in the sample size. There you go, Mario. You increase sample size. So if you want to increase statistical power, you increase sample size. That's exactly the answer. So they may ask you that. Okay, how do we order the appropriate test? All right, 10 minutes on this, and then we got to finish up with, with the biases. You guys will enjoy that. All right, so this is low yield stuff. All right, so we need to know a little bit about different types of scales in statistics. Right? So we need to know categorical or nominal. Right? This is different groups. It's either this or that. It's either a man or a woman. It's either an elephant or a giraffe. Nominal data, nominal scales compare among treatment interventions, right? Ordinal, we don't deal a lot with ordinal. This is groups and sequence where we compare quality, like class rank in medical school, quality of care in local hospitals. Interval, if we know anything from here, we got to know interval and nominal. This is the exact differences among groups, like height, weight, blood pressure. Most of the stuff that we do in medicine has to do some kind of a comparison between interval and nominal. We put those together a lot of times. And then sometimes you see ratios, right? So temperature measured in degrees and kelvins and stuff like that. These are called, yeah, this is low yield. I'll tell you a couple of things that are high yield. But it's nice to know when you guys read manuscripts, right? So we got to know nominal, I said, and interval. You guys remember nominal? What's nominal? What's a nominal category? Man or woman, right? Giraffe or lion, right? Something like that. What's interval? Blood pressure, right? Weight, height, that kind of stuff. All right, so a study could have nominal and then with interval sometimes. I'll show you a couple of things. So this is low yield, okay? All right, so the test that sometimes we get, they talk about is the ones right here, right? So it's the Pearson correlation. So we're really finding out, is there a linear relationship, right? Or the chi-square. So the Pearson correlation has to do with interval, right? Now, do you guys remember interval? What's interval? What's interval? Give me an example of an interval. Blood pressure, Angela says. Beautiful. Okay? Chi-square really deals with nominal, right? And you could have any group, any number of groups. So what's that? What's nominal? Right? So gender, right? Very good. Male or female, all right? And a t-test, all right? So t-test, we use a lot of t-tests and a lot of ANOVA. ANOVA is a type of t-test. It's a more complicated type of t-test. So the t-test has both intervals and nominals, right? So I want to compare blood pressure in men and women. I want to compare height in men and women, right? Two groups. Everybody understand that? But remember T? Right. T test. Right. Melanie said T test for more than two groups. That's right. So T tests, right? The T stands for two groups only. So remember that t-test, you could only do two groups. So this is something they may ask, right? ANOVA is a t-test with two or more groups. That's basically what it is. It's a complicated t-test. So I think of a t-test and ANOVA the same way, right? Basically, an ANOVA is more than two groups. Okay, the matched pair stuff and the repeated measures, guys, that's not stuff for us to know. Okay, all right. So the bottom line is your default choices, right? We don't remember anything else except the slide for correlation, right? It's for only interval data. Chi-square is for nominal data. T-test is for interval and nominal data, right? And what's ANOVA? Same thing, interval and nominal data, but more than two groups. Okay? All right. So a little bit about the Pearson correlation. It ranges from -1 to +1. You guys don't need to know that, but it's a type of test. I'm going to give you an example in case they show you something. Now they're not going to ask you this stuff, right? But a Pearson correlation, what it really looks for is a linear relationship, right? So it's trying to find relationship, right? Remember this in interval data, right? Interval data, right? Everybody okay with that? So you're looking at something like this, right? So you're looking at a diagram like this, which is a positive correlation, or something like this, which is a negative correlation. When you see that the scatter plots, right, follow a line or kind of like all together, right? Yeah, this is a Pearson correlation test. This is called a Pearson correlation test. The worst they could do here is show you something like this and tell you, what would this be consistent with? What kind of test is this? What is this? And you tell them, okay, this is a correlation test, right? So if the line is going up, right, that way, right, from left to right, it's increasing. There's a positive correlation. If it's coming down, it shows a negative correlation. Sometimes a positive or a negative can be important. If the plots are all over the place, right, then there's no real correlation. Okay? Okay. So the t-test, we said what? Nominal and ordinal data, right? So I got men, women, right? And I'm measuring height. I'm sorry, I'm comparing height, or I'm comparing blood pressure, right? Remember, two groups only, right? Two groups only. You can't, if you do more than two groups, you got to do an ANOVA, okay? Two groups and a single nominal variable, okay? Everybody okay with that? All right, very good, right? So this is what you get, right? So what am I looking at? I'm looking at height in men and women. Okay, so I'm comparing different heights, frequency of different heights in men and women. All right, so what's the height? That's the interval data, right? What's the nominal? Men or women? Okay, everybody okay with that? So these tests allow you, they're statistical tests. So when you do different studies, you're allowed to use them depending on the study you're doing and what you're studying to be able to come to conclusions. Right? So for example, if I was using nominal and interval data, I would use a t-test to compare the two groups and the interval data. Right? That's right. That is correct. Right? A single nominal data. Right? Everybody understand that? Everybody okay with that? Everybody okay? So that's okay. Very good. All right, so, and then lastly here, lastly is the chi-square. So we said this is only nominal data, right? And you could use any number of groups, right? 2 by 2, 2 by 3, 3 by 3. Usually the test to see if two nominal variables are independent. You know, for example, patients treated with drug versus patients with no drugs, right? So that's the typical chi-square. Right? So the Pearson correlation, right? Know what it looks like. Know the t-test a little bit because that has both interval and nominal data. And if you're doing only nominal, then, right, know that you probably need to use a chi-square. They can't ask you guys anything more than this. Okay, so this is what a chi-square looks like. You know, I gave drugs to one group, the other I gave to placebo, right? And I saw how many recovered and stuff like that. And I saw if there was an effect on these patients. Okay, all right. Let me stop right there. Let's take a 10-minute break. And then we'll come back and finish up talking about probably the most pleasant and the most important part of the night, right? Which is talking about the the way we view tests and the mistakes we make on them. Okay, everybody okay with that? All right. All right, everybody, we are at the home stretch. Okay, let me switch now to, we're going to finish up probably with the most fun of the lecture, and one of the most important ones, much more important than the stuff that we covered with the chi-square and so forth. All right, so we want to talk about study design. So I kind of left this last, even though it was earlier in your chapter. Yeah, they talk about study designs and so forth. So so here we go. So when we talk about study designs, one of the things that comes up and always needs a little bit of a definition has to do with bias and validity. So they want us to know that bias, the stuff that you guys talked about before, is basically deviation from the truth. We think it's, we report something else, but the truth is really not what we report and what we basically infer to in terms of inferring to the whole population. The other thing they tell us about is reliability and validity. Reliability is consistency or precision, and validity is accuracy or hitting the target. So sometimes they want you to understand. So for example, this is reliable. Okay, it's reliable that it misses the target, right? So it's not valid. This guy's always off to the left, so he's reliably off to the left all the time, but this is not a valid test, and this is not a valid result. What we want is we want reliability and validity. So we want this not only to hit the same spot, but we want it to hit the target all the time. Everybody understands that? So reliability, you're reliably off the target. That doesn't mean anything. I want to be reliable and on the target on the time, and that is called validity. In order to be valid, you have to be reliable. Everybody understands that? That's what we want a test to do. To be valid, right? And then hence, if it's valid, it's reliable. So you can see this is a good test. And this is a good study because it's valid and thus it's reliable. Okay? Everybody okay with that? So it's kind of like a play on words. All right? All right. So we have to talk a little bit about some of the types of bias, right? So a selection bias is a very important bias. They like to ask about a selection bias. Another word for a selection bias is a sampling bias, right? The sample is chosen from a non-representative study. Remember I told you guys before? I did a study in veteran men, right? Well, listen, maybe that's not representative of, the whole world, right? The sample is not representative of the entire population. So why do we do that? Well, I told you why I did it. Because it's a convenience sample as a Bergson's bias. You guys ever hear about people looking at hospital data? Why do people look at hospital data? Because it's convenient, right? It's convenient. They get the database. They can't go out and find people that don't come into the hospital, right? Okay? So, but what's the problem with a hospital database? Well, sometimes it's real. Sometimes it's good, right? If I wanted to look at acute MIs, okay, I would look at hospital databases. But looked at, for example, chronic disease, and I looked at the hospital database, right? What's the problem with that? I'm really looking at only people with this disease that come into the hospital, right? So it depends on the study. But typically, for chronic diseases, it's non-representative of what? The entire population. Can you guys imagine if you did blood pressure studies only in hospitalized patients, right? Or you did diabetes studies only in hospitalized patients? You'd only see only the DKAs or the hypertensive emergencies, right? You would have a very skewed view, right, of the population. All right, when I was a resident, and you guys are going to see this when you guys become residents pretty soon, I used to see sickle cell patients, and I thought every sickle cell patient was, had severe disease, right? Because I looked at, the hospitalized databases. Okay, and then another type of selection bias is the people that don't respond, right? So one of my friends, right, looked at, they went and they looked at in a clinic, looked at severity, quality of life in Parkinson's patients, right? So, all right, well, who comes to clinic? The patients with Parkinson's that are still kind of mild or moderate disease, right? So what happens to the very severe people? What happens to the very severe people with Parkinson's disease? Right, they're somewhere in a long-term facility. You never get them to come and clean. So her assumption was that people with Parkinson's disease relatively have a good quality of life. Well, the people that she was looking at, but that's not representative of the total, right? So the solution to a selection bias, right, to these databases from clinics or hospitals is to look at a random sample, or look at this. This is what we talked about yesterday. Weight the data. What does this mean? I told you guys yesterday. What does weight the data mean? What does that mean? We talked about this yesterday. All right, good. Beautiful, George. Adjust. Veronica says, adjust the data. Adjust it to what? We standardize it to what, though? To what? What do we adjust? What do we adjust it in terms of what? Severity, right? The age group, right? And severity, right? So if she weighted the data, she would see that she only has Parkinson's patients with mild and moderate disease, right? And that's how you adjust for severity of disease. Okay? Everybody understand that? All right, selection bias, right? Selection bias. All right, beautiful. Okay, now a couple of other types of biases. Now you guys are going to know this stuff, right? Measurement or error bias. Okay, gathering the information, right, distorts the information, right? You guys ever hear about the Hawthorne effect? The Hawthorne effect occurred in Chicago. Some guy says, well, that's right. Miguel says, light in workers. So they went to this factory and they said, listen, I think I could make your workers, this guy's from University of Chicago, we could make your workers, work better. And the guy says, you other guys are great. Come on in. You can do anything you want. Right? And they put all these lights in the factory and they showed that everybody worked better. Right? And they went back and they said, you see, if you put lights in all factories, you get 30-40% more output from your workers. Right? And then this guy, this smart guy, a young guy from the University of Chicago says, wait a second, let's do something else. Right? Yeah, just one big factory. Hawthorne was a big factory in Chicago, south side of Chicago. Right? So this guy says, let's put dark lights. Right? And he was selling lights, right? So let's darken the lights. Let's put a very dark environment and see what happens. Guess what happened? when they darkened the lights, they still produced more. You know why? Because it wasn't the lights, right? Because we were watching them, Tatiana. That's it. We were measuring. So they had these guys going around checking productivity. So what do you think the worker does if he's got somebody on the back of his neck, right, watching over them? They produce more, right? When you guys have Big Brother, there you got it. It's Big Brother, right? So they've taken that. They realized, that this was done with the lights, and they did it in a different way. They had like, people watching them and stuff like that because they know they would produce more. Okay? So the gathering the information, measuring the information distorts, right? It makes people do different things, right? Patients, you tell them I'm measuring, how far you walk. I put pedometers on diabetic patients. Guess what? They start walking more because they know I'm monitoring them, right? So what you got to do is like, put a pedometer on them for like a year. So after the first couple of months, they forget about it and then they go back to their normal, self. Or put it on their kids, right? See how far they walk, right? So everybody understand that the measurement themselves, right, changes outcomes in these patients. Another form of this is leading questions, right? So you don't say like, "How do you feel today?" to the patient. You say to them, right, you sure you don't have a chest pain? Are you sure? Are you positive? Are you 100% sure? Are you okay? Yeah, and they say, "Oh yeah, yeah." Now that you mention it, man, I got a little chest pain. Right, right. So you don't want stuff like that. So measurement error, right? Right. So what you want is you get a control group, right? Just like this guy from University of Chicago did. The control group was, he got a group with dimming the lights. Okay. Okay. Another form of bias they like to ask about is experimenter expectancy. So a lot of the educational studies, especially, have experimenter expectancy. So the expectations affect outcome, right? So you tell the teacher, you go into the second grade and you tell her, look, those 5 students, we just gave everybody a test. Those 5 students, they scored off, the reservation. They scored, third standard deviation, in the state and above, right? So you know what the teacher does? They, right, the affects outcomes. So the expectations, right? So the teacher starts, saying, okay, these kids are smart. I'm going. They play to them, right? And the opposite. There's an opposite effect too. Where you tell the kid, you really, you don't know what you're doing, right? And what do you think the kid does? Right? The kid starts, basically, right? Basically, making this happen, right? So you got to be careful about that because this affects patients' outcome, especially in education studies. That's right. So teachers will bias, Susma, right? Affect outcome. That's why you got to blind everybody, right? So what's this double blind business here? Because that's the solution. I know you guys are joking because you wouldn't have gotten to medical school. All right. All right. So double blind design, right? So what does that mean? Double blind. Who gets blinded? None of the parties know, right? So the patient and the investigator, right? The patient doesn't know who's getting the real effect. The researcher doesn't either. You ever see these radiology studies where they know like who's got the treatment or they know who's got the disease and they start, oh yeah, it's right there, it's right there. But before when you didn't tell them like who it was, they couldn't figure it out, right? So you need a double blind design study when nobody knows. Actually, the only person that knows is the study coordinator, and they got some kind of like formula to know like who's got what and who's taking what. Once they break that code and they release the information, the studies, it's toast. It's gone, right? Because you lose that double blind effect. Okay? So you guys, selection bias, measurement error, experimenter expectancy. Remember the teacher, right? You tell her these 5 kids are brilliant. Trust me, they're going to be brilliant, right? He or she's going to cater to them. Okay? So this is one of the most important types of biases. Fortunately, people have picked up on it and it doesn't really happen a lot anymore. It's called lead time bias, or you may hear it as screening bias. Okay, it's a false estimate of survival rate. So this is what happened when people were screening for lung cancer, 40, 50 years ago. They would do chest x-rays on people, right? And people said, look, I picked up cancer, earlier with the x-ray and then made them live longer, right? So look at here. You diagnose this right here, right? And the patient dies 5 years later, right? And look at here. That's if you had no no screening, right? So these are just positive symptoms, right? So positive symptoms here. So they come in with cough, weight loss, and you diagnose them, and they live 5 years, and they die, right? Now you did the X-ray right here, and you picked it up a couple years early, right? So Miguel says there's no screening for lung cancer, right? So you guys may hear about some screening of lung cancer in the next couple of years. Low radiation CTs in high-risk patients, but right now there is no screening for lung cancer, right? So that's true. But here's the problem here. This guy thought that he made a difference by doing screening, right? But did you make a difference on this guy? No. Veronica says no. What did you do? They died the same time. You guys see this here? Right here. So you're saying, wait a second, but I picked up cancer 3 years early. Why didn't I make a difference? All right, so who knows the answer to that? It's a big question. I made him worry 3 years longer. Because Atsuka says there's no treatment. You guys know the treatment of small cell cancer? There's no treatment. It's a non-curable disease. So very aggressive cancers, right? Well, chemo, but it doesn't improve survival. Maybe by a couple of months, they die at the same time, right? It doesn't make a difference if you catch it before or after. See? This is why it's important. Very aggressive cancers, right? Very aggressive cancers you don't screen for because you don't make a difference in outcome. No, breast cancer is different, right? Breast cancer, prostate cancer, colon cancer are different. That's why we screen for them. You guys ever wonder why we screen for only 3 cancers? Actually 4, if you include prostate. Because they are screenable, they're curable, right? Some cancers are not very, right? Cervical, breast, prostate, maybe, and colon. Okay? Because you can make a difference. The other cancers you can't. If it's a slow-growing cancer, you're not going to make a difference because you're going to pick it up later and still be able to treat it, like thyroid cancer. If it's too aggressive, right, you're not able to make a difference. So you didn't really help this guy right here. You told him 3 years early that he's got lung cancer, right? You didn't do this guy a favor, right? What you really wanted to show is where you make the diagnosis by screening here, right? And then these guys live 3 additional years, right? Beyond what they would have lived. That's when screening makes a difference. Okay, first one is when you don't screen at all. And this guy comes in with symptoms and is diagnosed clinically. Okay, like lung cancer is now. Right? B is when you do the screening. So diagnosis here through screening. S for screening. SER. Okay? Everybody understand that? All right, so everybody understand, we can't cure all cancers by screening. We don't prevent all cancers by screening. This is a big deal. You know, this thought that if you catch it earlier, you make a difference. It's not always. Okay? That's right. We need to use life expectancy here. Okay? Everybody understand that? Okay, very good. The first one is not screened. It's symptoms. The second one is screened. Okay? Then the third one is screened, but then you make a difference. This is like breast cancer. C is ideal, right? This would be something like breast cancer, colon cancer, where you use the mammogram here, you catch it, and they live 3 additional years or more. Okay? Everybody okay with that? So this is a big deal. Does everybody understand this? Okay? Well, that's right. You use life expectancy, right? Solution here is life expectancy. All right? Okay, very good. Okay, recall bias. All right, when you do retrospective stuff and stuff like that, and you ask patients about recalling accurate past events, please be very careful. You know, people, they formulate their memories in the past, like people, it's bizarre, right? You think you believe in it 100%. So be careful about making judgment on, recalls and especially past events. Well, confabulation is one thing. That's when people have dementia and stuff like that. But people just don't remember things and they kind of restructure their memories. So it's a form of confabulation if you want to think about it. And the way that you deal with that is you confirm through other sources. Okay? Right. So late look bias. All right. So this is what I was telling you. This is a type of stuff that I was telling you before. In severe diseases, right, we are less likely to have access to these severe diseases. Right? Everybody understand that? So severe diseases, where are they? They're either dead, they're in the hospital, right? Remember, I said you could only screen for cancers: prostate, colon, breast, cervical cancer. Everything else is not screenable. You guys may hear in the next couple of years about the possibility of screening with low radiation CAT scans, people that are high risk for lung cancer, smokers. Okay, that is it. We don't look for brain cancer. We don't look for skin cancer unless you pick it up clinically. Okay? No, selection bias is basically looking at the wrong population, right? So, oh, I see, with late look bias. Yeah, no, that's a late look bias is a type of selection bias, right? It's a type of selection bias. That's what it is, Tatiana, right? So you're basically looking at the wrong population. Usually the selection bias refers to databases. You got it like from the hospital or clinic, but these are basically equivalent. A late look bias, you're looking again at the wrong people. It's a type of selection bias, right? Remember, the severe disease, they're not in clinics, right? They don't come to clinic. They're hospitalized. They're end stage, so you don't get a good sense of the disease. Okay? Everybody okay with that? Okay, very good. All right. So a couple more biases that we need to right, and the other one is the loss to follow-up, right? So look, confounding bias. This is when the factors being right. Can anybody give me an example of that? The factor being examined is really related to other factors, so there's really no cause and effect. Okay? Anybody know an example of that? All right, so look at this. Well, no, drug users and risky sexual behavior? No, well that's probably okay. Hold on, let me tell you. All right, so hold on. So they did the study, I kid you not. They had the study long time ago, right? And found that people eating ice cream. So they looked at that. They were looking at drowning, right? Drowning in the sea, in the lake, and stuff like that. And they showed that there's a correlation between drowning and ice cream consumption. Okay? What do you guys think? I'm not making this up. I couldn't make this crap up. Very creative. Yeah, this guy published it in a good journal, and then everybody like flipped out. All right? So it's not ice cream causing drowning. What is it? What's the confounding? What's the confounder in there? Well, obesity. I like that one. Weather. When do most people eat a lot of ice cream? At the beach, in children, where? In the summer. When do people swim? During the hot months of the year. Whether summer or the hot months, right? There you go. That's the confounder. All right, so look at this. They did another study long time ago in Europe, right? This was before they could correlate smoking and lung cancer. And this guy picked up that people that had yellow skin in their fingernails, right? Yellow discoloration in their fingernails, right? Would get lung cancer. All right? So what do you guys think is the correlation? What's the correlation? Smoking. It wasn't the skin. It was smoking causing the skin to be discolored. That causes lung cancer. It was a tobacco stain, right? That's a confounding bias. Everybody understand that? All right, remember the ice cream, okay? All right, so you do multiple studies to kind of figure that out, right? And a meta-analysis, which we're going to talk about in a little bit. All right, so design bias. All right, so a non-comparable control group, okay? So we can't. I told you a selection bias and a late look bias are basically the same thing. It's a type of selection bias, okay? Everybody okay with that? All right, what do you guys think about a design bias? What do you think about that? A non-comparable group. Can you guys give me an example of that? So I had this friend who's a really slick guy, right? And he did this study on blood pressure medication, right? And look at this now. He wanted to show that his blood pressure medication worked, right? And he got a group of patients with a mean systolic blood pressure of 148. Anything above 140, right, is considered abnormal, right? You guys follow me? So his medication was given to these patients where their mean systolic blood pressure was 148. Right, so Fiorella got it, right? So this guy was a wise guy, right? So the control group patients, their mean blood pressure was 168, right? 20 points higher. So where are you going to have the most effect? On the 168 or the one? So, right. Luckily, right. No, you're not going to have enough. You're not going to lower blood pressure with one medication from 168. You're going to, the control group is 168, right? If I study an antihypertensive, stage 1 versus stage 3, what do you think which one is going to have the easiest drop in blood pressure to normal? The one that's 148, right? Everybody understands? So those are non-comparable control groups, okay? Everybody understand that? That's right. So Melanie says confounders related to the exposure and not to the outcome. So there's no cause and effect. Everybody okay with that? All right, now you guys get the design bias too, right? So you guys remember my friend? This guy was really smart guy. I mean, really smart. I mean, I'm not kidding you. But, you know, thank God there's pretty smart people in medicine to catch stuff like that. All right, so somebody, you know, said, well, you know, you can't publish the study because the mean blood pressure in the control group is 168. Right, there goes his Ferrari. All right, so look at here. Here's another question they've asked over the last couple of years. Do you guys know what random selection means? Random selection. Oh, we don't like mnemonics. We only like one or two, right? What's random selection? Okay, so Charles said bringing a random person into the study. Randomly picking people from the population. Everybody understand that? Randomly, just out of the blue. Okay? Okay? Equal chance. Everybody understand that? All right. What is random assignment? You have to have both. A good study has to have random selection, right? And random assignment. So Marco says randomly assigning them to the group. That is correct, right? So you pick people randomly out of the population and then, right? So you got random selection and then what do? You randomly assign them to treatment or control. Everybody understands that? Not the researcher. Remember, the researcher is blinded. The coordinator, right? They flip a coin, right? You put them into the group, right? You randomly selected 150 people. So now you flip a coin every time and they go to treatment or control. So it's not like one, you know, consecutive, right? You flip a coin and then you randomly put them to one or the other. You guys understand that? So they asked about this. What's the difference between random selection and random assignment? Random selection is pulling people from the population randomly. That's right. And then flipping a coin and then randomly assign everybody, right, to treatment or control. Everybody understands that is the best study that we could do. Random select and random assign. Okay? So everything is random. All right? So I said the difference between random selection and random assignment is random selection is I select 100 people randomly off the street to do the study. And then what's the second step I do? See? So let's go back here. So see here? This is random selection. Everything within the circle is my study population. Okay? So now what do? Now I randomly assign each patient to treatment or control. Okay? So you got everybody blinded here. The patients and the the physicians and the people doing the study, and everybody gets randomly assigned to treatment or control. Okay? Nobody knows about that except the coordinator. Everybody understand that? Random selection and random assignment. All right? This is a good question for you guys. That's a good question. All right. So let's do this. Let's see what you guys think. Well, Lucy said if you had only one, all right, you have to have a random selection. All right? So that's the very least, right? And if you could do random assignment, then that's even better. Both makes the study better, but if random selection you have to have in order to have a good, you know, randomized controlled trial. Okay? All right, so look at this question here. So there may be more than one question, more than one answer right. in order to assess what risk factors are most strongly related to having an MI, all of the hospitals in a single state agreed to participate in the study. The study's protocol requires that each hospital call the researchers whenever a patient comes to the emergency department with an MI. When contacted, a researcher will be dispatched to the hospital to interview the patient about past behaviors. To serve as a control group, an equal number of patients matched for age and gender who have suffered automobile accidents not involved with head trauma will be interviewed with the same questions. Although a number of biases may affect the validity of the study, what are the most likely? So you may get more than one or two. Okay? So tell me what you guys think. So there may be more than one. Right, so choice A definitely is one possibility, right? Late look bias, right? Maybe another possibility, right? You guys are okay with that? That look, if you wanted to study coronary heart disease, well, not every MI winds up in the hospital. So a lot of them stay home, right? And a lot of them die. They never go to the hospital. So you're looking just, maybe ST elevation MIs or something like that. All right. So which one of these are definitely wrong? Tell me this. Which ones are definitely not the answer? Okay, E. All right, very good. So E is definitely wrong. What's lead time bias? Right, so screening, right? Screening. So that's not a case here. All right, what's measurement bias? What's measurement bias? What's B? What's measurement bias? We're not really measuring anything right here. We're just gathering information, right? So measurement bias is Big Brother, right? So the what do we call that? What do we call that factory in Chicago, right? Where you're the Hawthorne effect. Likely not here. They're not going to affect outcomes here. Okay, and what's expectancy effect? Now this may be expectancy effect. What's that? Expectancy effect. The Pygmalion, the teacher, right? You tell her this guy's a genius, and she says, yeah, he really is a genius, and she makes him into a genius. Okay, so those are likely wrong answers, right? B, C, and E. So it's probably sample bias, maybe late look bias, right? Remember we said late look bias is really a type of sampling bias anyway. Okay, everybody okay with that? All right, that's the way you got to figure these out. Okay? Everybody okay with that? Expectancy effect for USMLE. That's the best one. All right? Very good. Okay, so look at this. So we have to know a little bit to finish this up to distinguish between observational studies. This is good material for USMLE versus experimental. Right? So what's the difference between observation and experiment? All right, the study that I did, that I gave patients antihypertensive medications, is that an observational study or experimental study? Did I intervene? Did I intervene? It's experimental. Of course I intervened. I gave the guy medication. All right, what's observational studies? I got people that are obese or less fit, and I watch them over time to see if they get cardiovascular events. I don't touch them. I don't tell their doctors to give them medication they want. I don't give a crap. I just watch them over time, right? So I'm watching this. All right? Everybody understand that? Observation versus experiment. Once I intervene, please be careful. Somebody told me a couple months ago, well, they only did a CAT scan on them, and no, I don't care if they tell them, do more exercise. Any intervention is experimental. If you tell them to walk 5 feet more a day, that's an experiment. You understand that? If you always have to be medication, any intervention at all is experiment. Okay? All right, very good. Okay, so look at here. You guys got to know a little bit about the type of studies, right? When we talk about observational studies, a case report is a single clinical subject. Okay? Why would I report a single case report? Think about that. Why would I report a single case report? All right, Charles. That's it. A rare disease, an interesting disease. I don't report, hypertension, in a single clinical subject. A rare disease. Case series is a group of clinical subjects, right? Can you guys give me a group of clinical subjects and I study a case series? Right. Appendicitis. I took all cases of appendicitis that came into my hospital in the last 10 years, and I looked at, right, their characteristic. Okay? All right. So now here's where the fun comes. All right? So cross-sectional study is a particular point in time. So if I look at a cross-sectional study, right, I looked at all cases with tuberculosis January 1st, 2013. What does this study also give me? All right, Miguel, wonderful. It's a prevalence study. That's what it is. It has prevalence characteristics. A point in time. Can you guys remember? Cross section, boom. I cut a slice of cheese, right? Right in time, right? You slice time at a moment. It's point prevalence. All right, so here it is. So now, look at this. We got some more important things here. We got case control study, right? Case control studies start from disease versus no disease. And where do they do? They go back in time, right? Disease versus no disease, right? I look at people with lung cancer and I compare them to 100 people with no lung cancer and I go back. This is a retrospective trial. Why am I going back for? Why am I going back? Well, Fiorella said it. Because I'm looking for risk factors. This is how people found out about the association between lung cancer and smoking. So they took 150 people. This was in England. They took X amount of people with lung cancer. They already had the disease, and they took another 100 people or 150 people with no lung cancer, and they looked and compared risk factors. And they found that people with lung cancer had an 8-fold possibility increase in smoking. Right? But but what? I'm going back in time, right? I'm doing a retrospective trial. I'm going back and I'm looking at their charts because they already have the disease. So what's a case control study? I go back. They already have the disease. What's a cross-sectional? A point in time. It's point prevalence. And then, right, what's the last one here? The most powerful one, which is a cohort study, right? What's a cohort study? Well, they call it a confirmation study, but it's basically a prospective trial, right? So some people said to them, the tobacco companies, they went and they told these guys in England, they said, "Are you out of your mind?" He said, "This is bogus." He said, "You prove it. This is a retrospective trial, and retrospective trials are no good, etc., etc. Right? So they took patients that are smokers now, right? And they followed them over time, right? They followed them over time. And what did they notice? They get lung cancer 10, 15, 20 years later, right? So now you're going from risk factor versus no risk factor, and you're following forward, right? Prospective, to figure out if really there is a correlation between smoking and lung cancer, right? Unfortunately, you're going to find out the way you don't want to find out. These people are going to get lung cancer. Okay? Now, hold on. Did we intervene at all? Did we intervene? What are these? Are these interventional studies or observational? Did we say to them, don't smoke? No. No, it's not unethical. I mean, you could intervene in a study. Tell them, listen, let me see if smoking cessation does something. But we were just observing. We were trying to correlate risk factors and, cause. Everybody understand that? Right. You got to prove it. That's exactly right, Mario. You got to prove it with a cohort. Okay? But let me be, I want to make sure everybody understands that. That's right. So Melanie says, for confirmation, don't you need a randomized controlled trial? Right. So this is the type of cohort study, right? A randomized controlled trial is a cohort study, right? Now, if you intervene, it's called a interventional, right? Randomized controlled trial, right? A cohort can be a randomized controlled trial, right? What's a randomized controlled trial? What do they control for? They randomly pick people. Remember I was saying before, random selection, right? Right? To control groups and stuff like that. They select people randomly. Okay? Everybody understand that? The way you guys read about randomized controlled trials, they're interventional trials, right? Blood pressure medication, lipid medication. Those, though, are interventional trials. Okay, but a randomized controlled trial could be an observational study, a cohort. Okay, everybody okay with that? Okay, let's talk a little bit about this here. So this diagram here kind of summarizes everything. All right, so 5 minutes more and you guys are free to go. All right, so look at here. Let's learn this stuff and then, we go off into the night. So the cross-sectional is right here. All right, everybody okay with that? So you see here, the case control goes back in time. The cohort goes forward in time. Case control starts from disease, no disease, and goes back in time to look for risk factors, right? Cohort goes forward in time because I have people that are smokers versus non-smokers, and I want to see, does smoking do anything? So basically, we're looking at them like this. This is a cohort study. Smoker versus non-smoker. Okay? Watch this. Incidence of disease 1 increased. Incidence of disease 2 increased. What am I talking about? What disease am I talking about here that increased with smoking? Cancer of the lung. Any other cancer? Any other cancer? What other cancers do smokers get? Mouth, head and neck cancer. Okay, esophagus, laryngeal. Anything else? How about COPD? All right, how about bladder? There you go. See? So I'm looking forward to see, like, does this, right, CAD, stuff like that. Right? So pancreatic cancer is probably not associated with maybe not. Okay? Everybody understand that? So I'm taking a risk factors, a lot of disease, that's right, and going forward. Okay? On the other hand, when you got disease versus non-disease, these are case-controlled trials, right? And now I'm going back and trying to figure out if they're associated with some risk factor, right? So I looked at people with colon cancer, right? And I went back and I saw, is it diet, right? Is it family history? Is it, something else? Okay? Everybody understand that? All right, so this is nice questions for you guys. All right? What's a cross-sectional study? Point prevalence. Case control goes back cohort, right? Yeah, we are going to finish everything today. Who said that we're not going to finish today? We're going to do everything. We're almost done. We got 5, 6 more slides. Okay? Everybody understand that? All right, so a couple of things here just to keep in mind. So look at here. Cross-sectionals, right, is one point in time. Everybody see that? Let me tell John and everybody. All right, so it tells you about prevalence of disease. A case control is retrospective, right? We don't know anything about prevalence or anything like that. We have no idea. Same thing about prospective cohort studies, right? We don't know prevalence in the community. We're just taking randomly and following patients. Okay? Everybody understand that? Okay. So you saw that the differences between that. All right, so look at this now. The last couple slides and we are done. All right? So I got to tell you about this and you're pretty much done. All right. So the interactive effects of fitness and statin treatment on mortality risk in veterans with dyslipidemia. All right? So the aim here, you guys got to tell me what kind of study this is. All right? So first of all, the aim is to assess the combined effects of statin treatment and fitness. All right? 10,000 dyslipidemic patients did a stress test and were assigned to different fitness categories. Okay, be careful. Now, Deline said this is experimental, right? But be careful. They got to tell you, did I give the statin or were these guys taking statins? Okay? Based on fitness and statin treatment. See, be careful. If I say I gave him statin, yeah, it's experimental. What if I say no? I'm just following because they were taking statins from the doctors. I didn't touch them. I didn't tell them to do anything. Right? Everybody understand that? Be careful. If these guys were already taking this stuff, you didn't do anything to them. Okay? So this is a study that we published and it went to a large journal, The Lancet. It was a cohort study, right? Do you guys get that? So it was an observational cohort study, right? So why is it observational cohort? Because I didn't tell you I intervened. Unless they tell you they did an intervention, right? It's a non-interventional study. It didn't happen in past time. I said I followed these 10,000 dyslipidemic patients, right, over time. Okay, everybody understand that? I followed. I started off looking at fitness and statin and followed over time. Everybody okay with that? It's not retrospective, it's prospective. I went forward. I started from risk factors and followed them forward in time. Okay? So watch the wording there. So they could be a little bit subtle. Okay? That's right. There you go. Atsuka said you started 15 years ago. That's what happens in when you do studies. You started 15 years ago and you publish 15 years later. Okay? All right. You guys ready for the finish? All right. So, cohort studies go forward in time. All right? Last two slides and you guys are done. So, we're only talking about incidence data, new cases only, because they're prospective. All right? The way that we measure risk in cohort studies, now you don't have to know anything else except this. Okay? Nothing more. You don't have to know retrospective trials, how to assess risk. You gotta maybe know this. This is not high yield. Maybe. So it's the last thing that I'm going to say. So you go forward in time in a prospective trial, you got incidence data, new cases only, and you measure this as what is called a relative risk ratio. Incidence of exposed over unexposed. How much more likely is one group versus the other group to get the disease? This is the only one that you have to know. And another way to look at the cohort studies is to do an absolute risk, which is also called attributable risk. And instead of dividing one over the other, now we subtract the exposed to unexposed. So basically, it's just you're looking at risk with a different lens, right? One is a ratio, the other one is an absolute risk, right? So how many more cases? 5 cases in one, 2 in other, the difference is 3. Okay? Everybody understand that? All right, let's do this example and wrap it all up. All right, so look at this. In this group, 20 white babies died in 1,000, right? They were looking at this very interesting population somewhere in Europe, where in this population, out of the 1,000 white babies, 20 died, right? Out of the black babies, 10 died out of 1,000. Okay? What is your relative risk and what is your attributable risk? What do you guys think? All right, beautiful. Oswald says 2 to 1, right? Okay? So how can you say that? It makes sense because if you tell people that 2 to 1, they don't know what you're talking about. All right? So what's the answer? You could take the 0. So white babies have twice as much chance of dying, right? So it's not see, it's comparing one group to the other, right? You understand? All right, so white babies have twice as much chance, right, of death, right? Hold on. So remember, you divide, right? So the denominators here cancel, right? You have 20 cases of white babies with the same denominator that die. 10 cases of black babies. So they're asking you, what is the relative risk in increase, right, in white babies? The answer is the relative risk increase is 2. If the denominators are not the same, you got to make the denominators the same. Otherwise, you can't cancel them out. Okay? And it takes more than 30 seconds. They ain't going to give you that. Okay? And plus, they know we hate numbers. Okay? We're bad. They're bad, but we're bad too. Okay? Everybody understand this concept? how would you present this? White babies in this population are 2 times as likely to die, right? Okay, what if I said both are exposed? You don't know what's going on here, what the risk is. You just find you're just presenting relative risk, okay? This doesn't mean etiology, Jose. It just refers to risk. I don't know, white babies were drinking different milk. I don't know what was going on. Who knows? Okay? It's different than reality, but this is a true study. Okay? All right, so listen to this. What if I said, how much are black babies less likely to die? What if I said it that way? All right, Ziad, you're all over this. Nadia, wonderful. Kanika, beautiful. So that's the answer. So if I said that, what's the risk black babies? The answer is 0.5. Okay? Everybody okay with that? So I could say one or the other and still the same. All right. What's the absolute risk now? All right, get that. What's the absolute risk? The absolute risk. What's that? There you go. 20 minus 10. 10 cases per 1,000. That's it. You guys got it, right? Everybody okay with that? That's it. How much more likely? How much less likely? That would be 0.5, right? And then attributable risk, how many more cases, right? 10 per 1,000 or whatever the denominator is. Everybody understand that? You don't need to know numbers for the retrospective trials. We got them in there for you. You don't have to calculate them. You only need to know relative risk reduction. You guys know this in step 2, 3, and the boards of medicine going to ask you this plus number needed to treat. So that number needed to treat, when you hear in the manuscripts, they get it from here, from the absolute risk reduction. Okay? Everybody okay with that? Okay. I'm going to finish there. Darlene, which slide are you referring to? So is this what you're referring to right here? This one? Before. Right here or this one? Is this the one? All right. You guys are okay with that? All right. You guys are going to remember the relative risk reduction. All right? You guys don't have to know the odds ratio. The odds ratio is the way we measure retrospective trials. Right? I said you guys don't have to know that for step 1. Okay? I know it's in the book. I put it there because a lot of people read from this and they go to step 2 and 3. They use the same notes. Okay? Everybody okay with that? All right. Thank you for your attention, everybody. You all have a wonderful night. Go over this stuff, right? Please, just a little bit. 10, 20 minutes. All right. Thank you for your attention. I actually, this is one of the most enjoyable classes. And please send me emails if you got any questions. All right? You all have a good night. Keep it simple. All right? You all have a good night. All right, take care, and thank John and Gabriel and Adam because it was a wonderful group. All right, take care, everybody, and the best of luck. All right, take care.